I won't be hosting this event alone. I have my amazing co-host, amazing lady, amazing woman who has an expanse of experience. Ladies and gentlemen, please make welcome to the stage Dr. Inyang Ayo. You're welcome, Dr.
Good morning,
Inyang.
everyone. Welcome to the 5th Scientific Roundtable of the Center for Integrated Health Programs. It's lovely to have you all here today.
All right, so we'd like to start with the national anthem, and I would like for you to please be on your feet as we take the national anthem. Volume, please. We stand, Nigerians are proud to serve sovereign more. All right, we'll take the national pledge. I pledge to Nigeria, my country, to be faithful, loyal, and honest, to serve Nigeria with all my strength, to defend our unity and uphold our honor and glory, so help me God. Give yourself a round of applause once again. Thank you so much. Thank you so much. Thank you so much. A quick welcome to our online guests. We know on YouTube right now we have views all over Nigeria, all over the country, all over Africa. We would like to welcome you to the 5th Scientific Roundtable. Please, can we give a warm welcome to our online guests? You're welcome. Our online guests, you're welcome. All right, a few housekeeping. We have the convenience over to my left, so you can just please take the seat, take the pavement behind, and then go to this to the convenience behind. And then we have also the registration booth outside. We also have the phone booth where you can take pictures, and then don't forget to also hashtag SRT 5.0.
So we'll start by introducing a special guest. We have quite a number of distinguished guests with us today. So to start off, we just saw the elegant lady walking. Her name is Dr. Temitope Ilori. She is the Director for National AIDS and Control Agency in Nigeria. Welcome very much, ma. Welcome.
A warm round of applause. Thank you.
We also have a few of the board members, board of directors for CIHP. We have Professor Eugene Okpere. Welcome, sir, and good morning.
You're welcome, sir.
We also have Mrs. Oluwatosin Abimbola Dokpesi. Welcome, ma'am.
You're welcome.
And we also have Miss Grace Izoin. Welcome. It's always good to have you and your support. Thank you so much. Also with us today is Mr. Nicholas Ubenyi, who is representing the National Coordinator for Network of People Living with HIV and AIDS of Nigeria. Welcome, sir.
You're welcome.
We also have the Director and Head of Child Health Division, Federal Ministry of Health and Social Welfare, Dr. Amina Mohammed. Welcome, ma. Nice to have you here. We also have Dr. Folakemi Aminashon. She's the Chief Executive Officer, Lagos State Agency for Control of AIDS. Welcome. We also have with us Professor Prosper Okonkwo. He is the Chief Executive Officer, APIN. Welcome very much.
You're welcome, sir.
We also have with us Dr. Jay Samuel. He's the Deputy CEO of Programs, APIN. Welcome, sir.
You're welcome, sir.
So while we go ahead, we'll go ahead to start the program, and we'll introduce other guests as they come in.
All right. Ladies and gentlemen, right about now, we would like to take the welcome address and the overview of the SRT. Why are we here today? Why have we come from far and wide? Why are we seated right now? And we would like to have the overview, and no other person to take this than our own CEO, Dr. Bolanle Oyelede. But before you come up, Ma, we would like to say a few things. All right.
So Dr. Bolanle Oyelede is a trailblazer. She's an icon. She's a phenomenal woman, a change maker, a prototype, a vanguard. She is one of one, and in my opinion, number one. So join me to welcome Dr. Bolanle Oyelede as she comes to the stage. So while she comes to the stage, she's a distinguished public health physician and visionary leader with over 35 years of experience in public development, policy development, health system strengthening, and international development across more than 16 countries in sub-Saharan Africa and Southeast Asia. A trailblazer in integrated health programming, she has led groundbreaking initiatives spanning HIV, reproductive, maternal, newborn, child, and adolescent health, and implementation science research in resource-limited settings. Dr. Oyelede made history as the first, please can we be clapping?
A warm round of applause.
Made history as the first female chairperson of the Global Fund's Technical Review Panel from 2008 to 2011, and later chaired the Independent Review Committee, IRC of Gavi, the Vaccine Alliance, from 2014 to 2018. Her leadership exemplifies the power of evidence, innovation, and country ownership in advancing equitable, people-centered health systems. Once again, it is my singular pleasure to welcome to the stage Dr. Bolanle Oyelede.
A warm round of applause for Dr. Bola as she comes. Please keep clapping till she takes the stage. Keep clapping, ladies and gentlemen. Keep clapping. Please don't stop. Don't stop. Don't stop. Keep clapping till she takes the stage. Keep clapping. She's almost there. Almost there. Keep clapping. Keep clapping. All right, you're welcome.
Thank you very much. Good morning, everyone. It's a pleasure to see you all here again as we mark the fifth edition of the SRT, the Scientific Roundtable. And it gives me great pleasure to see that despite all the odds, we have continued to do this. And just as Deima and Dr. Iyengar has flagged, this is really about continuing the dialogue, making sure that we are having the hard conversations that we need to have. This is most especial at these times. These times, since January this year, the landscape around health has changed so drastically that we've all been forced to take another look, to take a hard stand and say, how are we going to move forward together? And in that vein, we are forging new partnerships. We are keeping old alliances. We're fanning into flames alliances that have gone into the doldrums. And that's one of the reasons why we're here this morning. So I want to first of all say, for everyone who woke up this morning and said to themselves, I need to get here physically, I need to be online to be part of this process, good morning and welcome. So just to also welcome esteemed, for CIHP, we're very well known for the fact that we have very strong governance structures. So I will start by welcoming representatives of our board, Professor Pere, who is the board chair, and also a member of CIHP. So he's one of the owners of CIHP. We have a two-tiered structure, and he's on both tiers, really helping to navigate and direct. And I think I want to especially recognize Prof in the sense that he has continued, despite different challenges, to provide that support and ambience to enable us to grow as an organization, and we say thank you to him. Yes, thank you, Prof. And to all the other board members, board of director representatives, we still welcome. I want to especially welcome my sister, Dr. Temitope Ilori. As soon as we said this is going to happen, she said, count me in and I'll be here. So I really want to say thank you so much for coming. To all our panelists, I will say especially Dr. Anima Shaun. Today she's supposed to be hosting, she's a co-host in Lagos. There is the coalition of women, I'm not a politician, so I never know. It's Kauliso, but it's really about a lot of the women movement and politics led by the different first ladies and women who've held positions in Lagos. So it's a very strong advocacy group that comes together every year to do something. She left that to be part of us because she really believes in this. So I'm really happy to welcome you. Professor Lashley, I tell her that we're both standing in the midst of a pool of men. So I always like to really look at her and say, my sister, my compatriots, my trailblazer, getting things done. She's a renowned scientist, and she brings to the table a wealth of experience. So I welcome her and all the other panelists who will be joining the discourse with us today. My moderators, our moderators, we know them very well. Dr. Chris in the house, and my brother, Ms. Famtuji in the house. We just want to say thank you for coming up this morning to make this happen. What is the SRT? Over 5 years ago, almost 6 years now, we came up with this idea. We always come up with ideas at CIHP. And the ideas that we come up with, we often roll them out quickly, they work in the field, but we have a gap. We find that because we're going from one thing to the other, it's either we're surging, we're not surging, we're chasing, we're not chasing. We're doing so many things at different times that we hardly have time to take a breather and say, document the things that you are doing. Talk about the experiences that you have, share those experiences, and let us learn lessons from them, whether they be successes or whether they be failures. I always tell people that when you fail, I actually find it more powerful than when you succeed. Because when you fail, one thing you're absolutely sure of is that you don't want to go that route again. So you really would know that that is not working. So so from that perspective, we came up with this roundtable to say, let's set aside a day to look at those concrete things, look at the lessons that we learned, look at the challenges that we face, and come together as people with the same passion, with different perspectives, because that's really what shapes opinions and brings about change. And say to ourselves, how do we bring these things to fore? How do we make sure that they are making a difference? And I'll give you a concrete example. As we go through some of the things that will be shown, and also the notes that we've gathered, and the reflections over the years, you'll see that, for instance, we did talk about immunization. We talked about reaching the zero-dose children. Today we have a project, we will be talking about that, and we know that for Nigeria, this has become a real challenge that we have to face. We talked about the adolescents. We talked about the young girls. After that, we as CIHP, working with others, have gone up in the space of about 3 years. We've set up 3 youth centers that are functioning, thriving, and moving very strongly in Lagos. And so, and we do have other programs like that, other initiatives. And so as we continue this discourse, we don't want just to sit down and just talk. We want to make sure that we're walking the talk. We're making sure that the things we're talking about are things that we can action on. We actually have concrete actions out of the talks of the years, which we have measured over time and which are being implemented. And I think everyone, especially from the government and the non-state actors that are partners, deserve a round of applause for making sure that we are moving. So now, as we gather for SRT 5.0, as we call it, we stand at a new frontier. A new frontier in the sense, as I've said earlier, the global landscape is changing rapidly, too furiously, and really, really shaking everybody across the world. Funding is tightening. We can talk all the talk that we're talking, but if we do not have the resources to back that talk, it actually becomes a big challenge. But the point is, we can be very innovative in how we look for financing. Is it that we have maybe truly we look out for how can we be more efficient in how we are programming? How can we be more effective in the things that we're doing? How can we ensure that the investments we're making are geared towards getting to that goal and getting the results that we desire? But even as we have those discussions, we do know that demands are growing. We know it's not just about health now. We see the climate changes. We see the impact of climate changes on health. We see it in terms of different types of diseases that could be prevented. We know that in the last 5 years, COVID-19 has shown us that pandemics are real. They're not just the things we see in movies. They can actually happen, and we must be prepared from the smallest, tiniest community that we are in to make sure that we can identify very quickly what these elements are, disease elements or entities that can lead into epidemics and pandemics, and make sure that we are prepared as countries, as regions, as continents, to make sure that we are addressing and making sure that the world is secure in itself. So, but yet within all the challenges that we've identified, it lies our greatest imagination and our greatest opportunity. How are we going to reimagine health in terms of these challenges, in terms of these resource limitations? How are we going to make sure that despite these challenges, we actually continue to strengthen and build resilient health systems? How do we make sure that the learnings across countries, across areas, across regions are quickly gathered and fed into the process? So for us, as the convener, my message is very simple. The SRT must remain more than an event. We don't believe in events at CIHP. We believe in results. We believe in action, and for a long time we just do it very quietly without talking about it. So it must be a movement for accountability. How do we, especially at this time, make sure that each of us take it upon ourselves to, first of all, be accountable for what we are responsible for, but also make sure that we promote accountability, especially across country, as the primary framework upon which we are reimagining our health systems. How do we make sure that we are innovating? We're at the crux time. We have to innovate. There is no two way about it. We have to do things differently. We have to make sure that we're doing more than results, and we're spending very little to get very much more. We have to work together. We have to make sure that in all these, we're looking at equity. Equity from the sense of leaving no one behind. Whether it's that little girl in Sankara, if it's that little boy who's missed a dose in Suleja, every child, every young person, every adult must have an equitable chance of getting high quality health care and also be economically empowered to be able to stand on their own. So this is a forum where we want to make sure that the evidence that we have translates directly to action, where no one is left behind, and where Nigeria's voice adds to the global conversation on resilient health systems. I am deeply grateful to Professor Adesegun Fatusi, our keynote speaker for today. Segun had to change his flight to make sure he can be here this morning to be with us. So thank you very much. So I'm grateful to all our partners. First of all, they're not able to join us today, the United States PEPFAR CDC Centers for Disease Control for obvious reasons. And they actually had this vision of empowering local organizations to be able to grow. So they were the ones that actually supported the transitions of the Columbias, which was the backbone of where I started from, ICAP Columbia University, to transition the Harvard University structures into APIN, and Institute of Human Virology, University of Maryland, into IHVN Nigeria. And those structures, we must be able to give credit to whom credit is due. Those structures could not have been built without the support, the financial support, the technical support of the United States government, the PEPFAR structure, because they believe that when local ownership is given room to grow, then countries can really develop. So I think they all do deserve a round of applause, despite the challenges we're all facing now. So we thank them for the foresight, for the significant investments in nurturing local organizations to take the forefront in technical support, to make sure they actually promote truly country-led and country-owned structures. And it is this strategic vision that has not only strengthened Nigerian institutional capacity, but also laid the foundation for a more resilient and sustainable health response that reflects local leadership and ownership. If not for them, I'm sure Professor Lashley will not be sitting here. She's probably sitting she'll probably be sitting 365 days in Maryland. Prosper will probably be not professor at Bingham University, but probably be somewhere in the diaspora. So I think this is investment that is there. And it's not just about the leadership, but really more about the fact that we've been able to, over the years, to invest in local capacity, building a core of healthcare professionals, which at this point in time we have to discuss in terms of how do we ensure their retention and making sure we have sustainable structures to carry on looking at alternative routes to financing. So together, as we look towards the next 5 years, I am very confident that this scientific roundtable will continue to light the path towards stronger, fairer, and more sustainable health systems for Nigeria and beyond. So thank you, and I welcome you all.
Thank you. Thank you very much, Dr. Bola. Please put your hands together. Keep clapping. A warm round of applause again for Dr. Bola. Thank you very much.
My biggest takeaway from today is how incredible it is when people from so many different communities, organizations, different sectors of the government come together to really think deeply about how we can promote the well-being
story was a powerful reminder that when opportunity meets potential, the trajectory of a young person's life can completely change.
For me, CIHP Roundtable series as an opportunity to bring together policymakers, program managers, and community members in Nigeria to discuss contemporary issues around health. I started the company was the fourth series, which took place about a year ago. And is very particular, precisely key to address by Dr. Eshet, for example, about adolescent empowerment and adolescent health. And that set the scene for very impactful conversation, bringing in donors, bringing in government, policymakers, bringing in program managers to really discuss. I think one very critical point, that the guidance that done is actually allowing the voice of beneficiaries in the case of the last year's session, the adolescents to really come on stage and share their experiences from their own perspective. I attended the letter and the highlight of my experience including the nominal process. Stakeholders that attended the conference start together to review the problem. This problem will also start with the level of barriers, strategies to combat these barriers, and suggestions by stakeholders to make that the process for
A warm round of applause, ladies and gentlemen. Thank you, Dr. Bola, for that awesome welcome address and also letting us know why we have been gathered here today. Ladies and gentlemen, another warm round of applause. I'd like to recognize a few guests who walked in while Dr. Bola was giving the opening welcome address. I'd like to recognize the presence of the Executive Director, International Research Center for Excellence, IHVN, Professor Alashe Abimike. A round of applause. Abimiko, I beg your pardon. Ladies and gentlemen, I'd also like to recognize the presence of the Permanent Secretary, Kaduna State Ministry of Health, Dr. Aisha Sadiq. A round of applause. I'd also like to recognize the presence of the Country Director, Mother to Mother Nigeria, Dr. Imwa Chinyerem. Dr. Emmanuel Chinyerem, put your hands together, please, I beg your pardon.
Also with us today is Dr. Bola Gobert. He's the CEO of Georgetown Global Health Initiative. Good morning, sir. And just to also welcome, you're part of the team, they are the workroom of the house, our in-house directors, Dr. Francis Ogirima, Dr. Collins, and Mr. David Badabas. Good morning and welcome. All right, to take the opening remark this morning, we are going to welcome to the stage Dr. Temitope Ilori. She's the Director General of the National Agency for the Control of AIDS. Her impressive academic background includes an MBBS degree from the University of Ibadan, residency training at the University College Hospital, and a Doctor of Philosophy fellowship focused on family medicine and primary care. Dr. Ilori's research interest aligns with NACA's mission, encompassing areas like primary care, immunization, public health, nutrition, non-communicable diseases, and women and child's health. Ladies and gentlemen, a round of applause for Dr. Temitope Ilori.
Thank you. Good morning, distinguished ladies and gentlemen. I had to take a catwalk like my senior sister, the CEO of CIHP, our own trailblazer, shattering glasses, mentor. She graduated from the first and the best College of Medicine, University of Ibadan. Dr. Prosper can attest to that, and so do I. We are all alumnus and we are all proudly Ibadan. And we are so proud of her achievements. She's first in many aspects, and I'm proud by association. So I stand before you this morning, proud to actually give this goodwill message. But it's always very difficult to step into people's big shoes after that very enlightening, very elucidating speech. I'll just keep mine very simple and short because she said it all. But I would say that as a government representative here today, it's my pleasure to join you at this morning's 5th annual scientific roundtable series. And the theme this year, which is Reimagining Health Systems, Innovation, Ownership, Quality, and Sustainability at a time of global transition, is both timely and essential to the continuity and the resilience of our national health response. Indeed, there has never been a more critical moment to strengthen national ownership and domestication of Nigeria's health programs such as this. As a country, we must continue to build systems that are sustainable, that are resilient, and are capable of delivering equitable health outcomes for all Nigerians. I believe, going by some of these key pillars of domains of sustainability, as a government, we've been working with these key, pillars, and one of such pillars is political leadership and commitment. I dare say that this current government, led by our President Bola Ahmed Tinubu, has actually demonstrated strong leadership and renewed commitment to strengthening Nigerian health system. You are aware of the Renewed Hope Initiative, the SWAP approach, and so many other initiatives being led by the coordinating minister and the Honorable Minister for Health and all the other health workers or stakeholders in the health industry. In the area of HIV/AIDS, to leadership and commitment has been demonstrated. You are aware of the $200 million that was ring-fenced as an emergency intervention fund after the January episode and all that. You are aware of the creation of the ATM, AIDS, tuberculosis, malaria National Technical Working Group, which I co-chair. You are also aware of some of our efforts to integrate our supply chain and also, our delivery systems in terms of to ensure that we advance the multi-sectorial integration efforts to ensure a more coordinated, efficient, and impactful service delivery. Also, another pillar is enabling laws and policy. The PVAC, Presidential Value Added Chain Initiative, was created by this government, and the whole essence is to set an enabling environment. We have the tax breaks, we have the what do you call it now, when you don't pay duty-free for pharmaceutical commodities and all that, and this is to encourage production. I'm aware that we've signed a lot of MOUs, well, not a lot, a few MOUs with some local organization, local manufacturing companies, so they can start the production of rapid diagnostic test kits, both for HIV, for malaria, for sugar, and all that. We've also signed MOU for even local production of antiretroviral drugs, and I'm also aware that even some, what do you call it now? What's the right word now? Some companies outside Nigeria, I don't want to mention names now, but I do appreciate, I've signed MOU with Nigeria to bring production, of some of their commodities, to start local production of some of their commodities here in Nigeria so that we can improve, the production and service delivery generally and make it affordable. So it's all in a way to determine, to ensure ownership, national ownership, to ensure that we are reimagining, and ensuring sustainability at such a time like this using innovations. You are also aware that we are part and parcel of the Clinton initiative that negotiated for the reduction in the price of the latest innovation, PrEP, which will now be coming at a cost of about $40 as against $25 per dose then. And even starting from next year, we are going to have a rollout, of this clinical trial, which being supported by the Global Fund and other organizations. I must lend my voice to that of Dr. Bolanle to appreciate all our international donors, particularly the US government and other partners, Global Fund and so many other partners, for their support, particularly in the area of HAM, HIV, tuberculosis and malaria over the last 2 decades or more. And we just believe that now is the time for that needed and very essential transition for us to be able to take that ownership. So we would say they should not let go now, but rather we need that hand holding, and we need that transitional plan for us to be able to take up that role for sustainability and welfare of our citizens. In closing, I will say that NACA is fully committed to increasing domestic financing through integration of HIV services into both the national and the state health benefit package. We are talking to so many, to the National Health Insurance Agency. Many of our vulnerable groups, people living with HIV, have been uploaded on the National Health Insurance Scheme, and they are receiving, benefit package on that scheme, and we'll continue to do that, as well as the vulnerable groups like mothers and children. And I will say that the goal is to close the funding gap for this key vulnerable group, to expand local resource mobilization, and to strengthen Nigeria health security. Like I said, let me just try to keep it short and simple, and to say that finally, we will continue to build resilient, people-centered systems supported by robust data, skilled human resources, and integrated service delivery approach, which goes beyond HIV, but is a systemic and holistic health, community, and social system. I thank you, CHIP. I thank everybody. I acknowledge the board of directors. I acknowledge, of course, my seniors, and particularly the keynote speaker, Professor Fatusi, a very big brother. Thank you, and God bless you all.
We'll further recognize some of our guests that just joined us. So with us this morning, we also have Dr. Funke Lawson. She's the Executive Chairperson, Zankli Hospitals. Good morning, Ma, and welcome. We also have with us the Director of Public Health, Kogi State, Dr. Francis Aku. And we also have with us the Executive Director of Kogi State Primary Healthcare Development Agency, Dr. Muazu Musa. Welcome, sir. So to take the keynote address this morning, we would welcome our distinguished guest.
All right, ladies and gentlemen, okay, thank you. Ladies and gentlemen, before we go into the keynote address, I'd like to read the bio of the keynote speaker. All right. Professor Adeshegun Fatusi is a distinguished Nigerian and Pan-African public health leader, widely recognized for his groundbreaking work in sexual, reproductive, maternal, and adolescent health. With over 3 decades of impact across academia, international development, and public policy, he served as the reproductive health advisor with UNFPA, Director of International Research at the Guttmacher Institute, and Vice Chancellor of the University of Medical Sciences, Ondo, transforming it into a premier center for health sciences education in West Africa. A professor at the prestigious and great Obafemi Awolowo University. A round of applause for Great Ife. He has also led the Institute of Public Health and College of Health Sciences. Professor Fatusi chairs Nigeria's National Technical Working Group on Adolescent Health and advises the WHO Africa RMNCAH Technical Advisory Group. He is a fellow of the Nigerian Academy of Science and Medicine and has authored over 100 scientific publications. A round of applause, ladies and gentlemen.
a prolific science and medicine, a prolific researcher and policy strategist. He has also led over 25 national and international studies and co-authored major national health strategies. His leadership continues to shape equitable, evidence-driven health systems and youth development across Africa. Ladies and gentlemen, with a warm round of applause, a big welcome to Professor Adeshegun Fatusi. Please keep clapping, keep clapping.
All right. I have to ask the CIHP CEO. I said, who wrote this? Good morning, ladies and gentlemen. It's a great pleasure for me to be here this morning. And permit me to just abide or adopt the protocol that has been so well laid. But that said, let me quickly recognize a few people. Let me thank profoundly my friend, my colleagues, the CEO of CIHP, Dr. Bolanlo, for the great work she's doing and for the privilege to be here this morning. I guess he's the only one that could have made me to come to Abuja today. No, it's not the only one. There are two of them who can, and both of them, they are sitting together. Let me acknowledge my other friend, brother, Professor Prosper Okonkwo, who also we've worked together for decades, the CEO of European Public Health Initiative. Of course, I cannot but salute my sister and friend and colleague and Director General of NACA, who is representing government today. Please permit me to just stop at this moment. And all council, all the members of the board of the CIHP, Bob, why are you looking at the ground? That's why I don't want to recognize you. I saw you. It's a great pleasure to be here this morning, and I'm just going to go on to make my presentation. Am I using this? Am I using? Are you collecting? Am I controlling, or you are controlling for me? Yeah, okay. All right, that means I have to be a bit slower. So what I'll be talking about this morning is the topic, reimagining health systems at a time of global transition, and focusing particularly on the Nigerian health system. There are three things I'd like to do in the next 45 minutes or thereabout. Number one, take a quick look at what we all know is happening in terms of what's happening at the health at the global stage, the transition and trajectories that we are seeing. Number two, think about realities and the new paradigm we have on the table. And finally, from all the efforts, how do we truly get to where we want to go? How do we get a system that will do exactly what the Director General of NACA, the CEO of CIHP, and so will do? So let me start. Health at global stage, a new world. Indeed, it's a new world. We all know that. And there's various factors. And of course, I can't talk about all of this in 45 minutes. We all know about what's happening in terms of demographics. We've talked about young people, demographic dividend, how the world is changing. But at the same time, we also know aging is taking place in many parts of the world, including our country. And many people are beginning to struggle with what they do with their old father and old mother. There's no place to take them in the afternoon and things like that. Number two, we also are very conscious of the challenge with health security and all the epidemiologic dynamics that goes with that. New infections, again and again. Thirdly, climate change. I think it's Dr. Elodin that spoke about climate change a few minutes ago, and the environmental hazard that has brought forth. Fourthly, the technological advancement and challenges. Somebody told me that if there is going to be a world war next time, it's going to happen because of WhatsApp or TikTok or one of those things. That's going to use AI to create something that was going to spell a war. And of course, what we also know very well, the economic and geopolitical volatility. I'm going to take a minute, just talk about the epidemic dimension, and then I'll go straight on to the issue of finance, which I think is the main issue. But as we are all aware, increasingly, we are witnessing epidemics. They are occurring at much shorter periods, they are occurring with greater impacts, and they are occurring with more disruptive tendencies. And as we continue, we just see that this continue in a wider way. And that tells us, whatever we do, we must not take our eyes off the ball of the whole issue of air security. Otherwise, all other things will get stopped by the challenge of air security. Next, one of the papers I read, Intensity and Frequency of Extreme Novel Epidemic, two quotations from that paper. It says, using recent estimates of the rate of increase in disease emergence from zoonotic reservoir associated with environmental change, we estimate that the yearly probability of occurrence of extreme epidemics can increase up to threefold in the coming decades. End of quote. And it says, together with recent estimates of increasing rates of disease emergency from animal reservoir associated with environmental change, these findings suggest a high probability of observing pandemics similar to COVID-19, probability of experiencing in one lifetime currently about 38%, which may double in the coming decades. And so, the question for us is not, is there going to be a pandemic? The question is, when? And the when may not be very far away. But let me move on from there to talk on the issue of where we are in terms of financial volatility. Every time we think about this, the first thing that jumps to our mind is, wow, President Trump. But take a look at the quotation from the UN Trade and Development. It says that in 2023, aid to developing countries declined for the third consecutive years, affecting sectors crucial for sustainable development. Even before Trump, what it shows is that this has started declining, but we are not paying as much attention because we just needed that catalyst that will catalyze other action. Of course, you know what they have done. They spent to USAID, withdrew 500 million from Global Health Fund, and that is not just about USAID, it's about the global environment, the global health system, WHO less funded, UNFPA not getting funded again, and all of that. And that means a lot of disruption in health services across the world, particularly in low and medium-income countries. Next slide shows that it's not all about Trump. It's not all about America. No, we'll go back to the last slide. This is the policy brief by OECD, released in June. And one of the things it shows is that the OECD projects a 9 to 17% drop in ODA in 2025. This comes on top of a 9% drop in 2024. But for me, what is most particularly scary or challenging is the next sentence. The outlook beyond 2025 remains highly uncertain. And that graph shows the pattern we've seen in the last couple of years, in the last years, and it tells us challenges, and more challenges. Next slide. Of course, we all know the implication of this. With the less amount of funds available in the health system, we know that there are less white workers that are being employed, services have been disrupted, supplies have been disrupted. Certainly, what we see is a compromise in the availability of services. We also see a decrease in the quality of the services even when they're available. And that will mean there will be decreased access, and of course, it will worsen the health status of our country, of many countries. But just to take one example to show how this touches us as a country. This came from a work published in 2023 that was showing the funding that goes to contraceptive commodity in Nigeria. And each of those circles represent the proportion of fund that came from a particular organization. The biggest circle is UNFPA. And here we are, all funds from America to UNFPA withdrawn. The next biggest funder is USAID, withdrew totally. And therefore, you will not be surprised at what the scenario will be. Next slide. As of July 1, Nigeria has a 52.1 funding gap in our contraceptive commodity. That means so many people who want to use family planning will not be able to access it. And we're talking about a country where teenage pregnancy over the last 20 years had only decreased by 8%. In the last 20 years. We're talking about a country where abortion, unsafe abortion is a major challenge to maternal mortality. And so imagine now that people cannot access, and must say that, of course, federal government of Nigeria has paid this 4 million that is promised, but that's only 8%. And the states only contributed 0.6%. This is not going to take us anywhere in an age they are in currently. Let's go to the next slide. One of the questions I think is more important. Chatham House published this a couple of weeks back, and late last or recently. See, it's titled Africa After USAID. Who will pay the health bill? Can you go on, please? What caught my attention is a particular quotation. It says that the retreat of the US from global health has left more than a funding gap. Most times we are thinking about the funding gap, but this has left more than the funding gap. It has exposed the weakness of a system that leans too heavily on a handful of donors. And so if any of the donors sneezes, the entire world catches cold. And the next slide then posts what I think is perhaps the most important question. It says, will African governments allow the circle of dependency to continue, or will they reassert sovereignty over their own health system? There's no doubt that health aid has done a lot for the system across Africa and across Nigeria. But we also know that there have been challenges even with the aids, because we know that when there's fragmentation that comes with aid and there's no integration in the health system, it also leaves some perpetual problem for the health system. But the question is, perhaps, can this be an opportunity to change the game? Can this be the moment that we need to change our approach? Is this a time that we can just step into the crisis and begin to determine for ourselves how our own health system will go forward? Next slide. The very simplistic way to think about this is that there are only two things we need. Increased funding. Shop for new partners. China is available, hopefully. And shop for new partners. And then let government increase more. Let's mobilize more money from private sectors. All of those are important. And then, I've not finished, sorry. Maybe he's telling me move on. We always think that it can be a balance of two things. Increase funding, decrease leakages, decrease corruption, decrease all those kind of compromises. That's a simplistic way of thinking in the way and the time we are in. What really should we be thinking about? How do we define this challenge? Next slide. Now, the common question that I hear people ask on the street and among friends around actors is to say, how can we maintain and sustain the existing services given the availability of less funds? Even if there's no fund, if there's no more money, what can we do with what we have? That is not the question. It will not lead us to an answer that needs to redefine our health system. Therefore, what is the question we should be asking? Let's go on. The key question and the real issue is this. Go on, sir. The challenge of not, you have to, don't worry, we're communicating all of that by every means possible. The key question is, how can we design or redesign our health system to function optimally, powered primarily, not totally, not exclusively, but powered primarily by domestic resources? That is the question. Not about how do we provide, no. How do we change the dynamics, the paradigms of the system to make it more functional, more effective, more result-oriented, and based on what we have as a people? Next slide. All right. Will we embrace challenge? That's the question. There was a conference in Accra in August, the African continent, where they were trying to talk about Africa's sovereignty and sovereignty. And this was the statement that WHO DG made at that meeting. He said, but in this crisis lies an opportunity to shake off the yoke of aid dependency and embrace a new era of sovereignty, self-reliance, and solidarity. End of quote. The question is not, is there a challenge? The question is not, is there a crisis? The question is not, is there an opportunity? The question is, will you embrace the challenge and will you move on to the dynamics of opportunity? Next slide. The journey from donor dependency to domestic sustainability isn't just about finding new money. It's about reimagining how systems are structured, how they are delivered, and how they are governed. That, ladies and gentlemen, is the crux of the matter. Let's move on as we talk for a few minutes about the Nigerian health system, our current realities, and the new paradigm. Of course, we know where we are. I don't want to spend time quoting some, but we know where we are. We know that we have some very unenviable statistics. We know that our under 5 mortality rate is the second highest in the world, and only one of the 4 countries in the world that has one under 5 mortality rate of more than 100 over 1,000. We know that our maternal health status speaks volume about the neglect of our women and how much we have not paid attention to the issue of sexual and reproductive rights, even among adolescents as well as older women. We have the highest maternal mortality burden in the world, according to WHO, 75,000 maternal deaths per year. We have the highest maternal mortality ratio, and we can go on and go on. WHO says we contribute more than a quarter of all global maternal deaths. And the World Bank says that when you take any health indicator, we rank between around the worst 5 or the worst 10, whatever indicator you take. Next slide. But are we in an era of hope? I can see how DGs look at me. Yes, this was the promise in 2023, that there is hope in the air. And I honestly believe that for most Nigerians, particularly most health professionals who are around, it's because we believe that there's hope in this country. Otherwise, we all have jackpot. That there is hope, that this was the promise. And I like the sentence. And if I ever have an opportunity to meet President Tinubu, this is what I'll quote to him. We shall invest greatly in the health of our people. End of quote. Next slide. Well, you know, in the last 2 years, to be fair and to be honest, we've seen a lot of traction. The health minister and this system has told us there are 4 strategic approaches to what they're doing. Effective governance, efficient, equitable, and equality health system, unlocking value chains and health security, and on. These we know. Next slide. We also know the priorities. That the priorities are not only look at issue of systems, but also you look at issue of services. Let's move on. These are, I don't want to spend time with this. We know all of this. That we say, okay, 17,000 PHCs, 774 secondary facilities. We're going to ensure that they are able to perform better than they've performed. Next slide. All right. And one of the statements that I read in the ministry documents, it says it's business unusual. And I'm going to leave it to you to answer the question. Is it business unusual yet? Or we're on the pathway to business unusual? But there's something for me that I find very encouraging. That one of the things that this agenda has done is not just looking at what we do in the health system, but also looking at structures that surround the health system that are important to the health system. A couple of years ago, I was leading a team to a state to see the director of nursing. And she said to me, somewhere along the line, she said, what do I think about traditional birth attendants? And I told her, it's not an important question to me. And she looked at me. This was years back when people were saying TBAs. And I asked her a question. I said, "Ma, did you deliver with a TBA?" She said, "No." I said, "Do you have a daughter?" She said, "Yes." "Did she deliver with TBA?" She said, "No." I asked her, "Do you have good friends?" She said, "No." I said, "Why did you not deliver with TBA?" He said, "Because I'm educated." I said, "That's the answer." She said, "After TBA is wasting your time." If people are educated and they have the means, they will take the right decision for themselves. If they're educated, they will take the decision around family planning. And so when I saw a whole plan that was not only just looking at the health, but recognize that they have to do something about the open education and open governance, it encourages my heart that perhaps we are truly in a season of hope unusual. Next slide. Oh, this is what you see. Hope government, or hope governance. We work around increasing PhD financing, we improve budget for PhD, strengthen the performance and finance management backbone, and we'll do something about human resources before the rest of the game. Let's go on. All right. And again, here are the indicators of the LDIs. Because now it is about results, it's about results to drive financing. And they've specified very interesting results: improving quality of services, improving utilization, and improving resilience. If we truly are able to deliver on these three things, Nigerian health system will change. The challenge is not about pronouncing them. The challenge is not about articulating a response. The challenge is not even at the federal level. The challenge is at the subnational level. You can do all you like in Abuja. It makes absolutely no difference until the state governors can embrace them and local government can tap into them. So this year, they are nice, but they translate into ownership of those agenda at the state level, they will not get to anywhere. Next slide. All right. So where are we? I don't know if you saw this report. When I saw this report, I was very interested in it. You know, academia, you always look at reports and statistics. And when I read through, my conclusion is this is work in progress. There are a lot of activities. We do this. But activities are not necessarily results. But it's also unfair to expect results too early. But the point is, what Nigeria needs, what Nigerians are looking for are not activities. What Nigerians are looking for are results that shows an improvement in their estate and their health system. And I do hope that as we see the next year's report, something else will go beyond a lot of activities to a lot of real outcomes. Next slide. Now, let me go to my last part of this presentation. Reimagining the future from tractions to targets. So, like I said, there's been a lot of traction, activities, intentions. So what do we need to do going forward? Next slide. The core question I think we need to answer is how can we reimagine the health system to best confront the existing challenges, because there are huge existing challenges, and at the same time meet the demand of the future and meet unprecedented global changes and transitions in a sustainable way. That, I believe, is the core question we need to answer. Next slide. And I'm not going to answer them, hopefully. I hope that we all answer them. I share a few thoughts, and I look forward to listening to the panelists and all of us to create answers. Even as we go, there are current challenges that we must continue to confront. Number one, the huge geographic disparities across Nigeria in health outcomes. Some states, if they are independent countries, will rank so high in this country. Some, if they are independent, we know what it will be. And we cannot continue as a nation. We are in one place, we are seeing huge improvement, another place, we are seeing huge deficit. Number two, there's high level of inequities, poverty, education. All of those factors are such a determinant of health will make a whole difference. If we don't address them, we will not move forward. Number three, access to essential health care is a big issue, and quality of care is a big issue at every level, including tertiary, and now we are going to quaternary, or maybe we go to 15th one day. But I think that if the quality will improve at the primary care level, I was reading the report. The report says about 67% of Nigerians actually attend, they go to public health facilities first. The national report, the State of Health report, says that about a third of Nigerians think that the health system had even gone worse. That's what the report says. So, government spending has improved. Now we've got 5.18% in last budget. But our government spending on health per capita is about 0.5, which is one of the worst in the world according to World Bank, and complex health governance structure. I'm glad that this government has reached a compact with state governors. It won't be the first time. National health will reach compact. And so we must ask ourselves, what do we do to truly transform this complex system? Or how do we work? How do we navigate the complex of the system to achieve results? Next slide. Oh, Nigeria has, God bless Nigeria and policy makers. Nigeria has policy. Oh my God. Just ask it. Even this government has added at least 2 new ones. Migration policy, there's the policy on climate adaptation. Policies and policies. Nigeria has policy. Next slide. No, this slide, I was part of the reform in during the era of during Obasanjo's regime, the health sector by Lambo. And during the Easter, one of my friends sent me this wicked joke. He said, may your life never be as meaningless like OBJ's reform. I'm like, and OBJ reform, many of them did something nice for Nigeria. But it's about perception and Nigerian felt. I'm like, this is what these guys think, that all this reform is simply meaningless. The point I'm making is reforms might sound nice. It does not convince anybody until they see results. Next slide. Oh, yes, we have experience in reform. One nation, several reform policy agenda. Reverse national policy 2004, former sector social insurance 2005, further air reform 2024, national air 2014. Many reforms, but where are they taking us? We are still at the point where we have the worst maternal mortality in the world. We are still at the point where we have the second highest under 5 mortality in the world. Despite decades of reform. What does that tell us? Next slide. What does it tell us? Perhaps we should reflect for a moment on some of the lessons from previous reforms. There's a paper that was looking at air reform in Nigeria and was looking at the policies of primary care and universal health coverage. And there are 4 points that paper made. Number 1, the political and institutional challenges hindered the implementation of Save 1 Million Life program. Horizontal and vertical fragmentation of authority within the health sector also impeded coordination. Thirdly, electoral circles led to frequent turnover of sectoral leadership. I was at another meeting last week where I was presenting. And before we presented, the night before, we had a meeting with some commissioners, and I know one of the things that struck me is that by June next year, every activity will stop. It's all politics, almost. And the governors actually have like almost 2 years only to act. Because first year, you are settling down. Fourth year, you are campaigning. Anything that does not happen in 2 years, it's not like to happen. And unfortunately, when you begin to see changes in political leadership in the state, you see that there are things that people are doing that should have brought the state forward. Somebody drops it because it's not his party. I was in River State a couple of weeks back, and I just was going by the road, and I saw these huge pillars. And I'm like, I just asked my host, I said, what's this for? He said, it's for those those flight train that one of the governors was doing. I'm like, so why did somebody not complete it? He said, no, he has done his own. We have to do our own. That takes us nowhere. If you look at states that have made great progress, and I don't want to mention states, maybe I should, like Lagos, it's because there's a continuation of agenda. And so sectoral leadership, where we change plan every 2 years, because not my party, it's not going to take anybody anywhere with any program. Anyway, that's the lesson. And senior politicians did not adequately support the initiative. That was the conclusion, lesson learned from that initiative. Next slide. Another initiative, the midwife service scheme and free MCH program. Did it succeed? It failed after a while. What were the lessons? The failure of the government, I'm quoting, the failure of the government, particularly state and local governments, to honor their financial commitments to the program led to the demise of that program. That's what last year Commission of Health said about that. Listen, ladies and gentlemen, next slide. If you don't learn from those, then we are going to tread the same path, failure, after all the efforts. So what do we need to do to reimagine the health system? May I remind you about what we define about the health system in Nigeria? Even when you open the State of Nigeria Health report, it's the first thing you find. That the Nigeria health system is not about Federal Ministry of Health. It's not about the state ministry. It's not about the parastatals. But that's what you find happening most times. It's Federal Ministry running around of state ministry doing activities. But the National Health Act says the Nigerian health system consists, in addition, all local government health authorities. Where are they in the health agenda of this country? World health committees, village health committees, private care providers. What initiatives are going on now in terms of primary care provider? We're not going to change the system if all we are going to focus on is the federal, state, local system, and alternative health care provider. And I said, as I was thinking about this, but even beyond that, the stakeholders that facilitate the actions also matter. I'm talking about development partners. I'm talking about academic and research institutions. I'm talking about professional institutions. We need to bring them to the core of what we do, otherwise we are not likely to move very far. Next slide. Can I take you back to the basic? The health system. Basics. One of the famous coaches in America was talking about his team after they won. And they asked what's the trick. He said, we always pay attention to the basics. Every time we take our eyes off the basic, we are going to run through. The basic is fine. It's very easy. That when we think about the health system, we all know this, and I'm not giving a lecture to, I'm just conversing. Oh, the first thing to realize is that human resources is the linchpin. Buy all the medicines. I don't want to say sign all the MOUs, because she's my sister, so for me. You know, buy all the medicines, build all the hospitals. When health workers feel they are not appreciated, when they feel they are not valued, when they feel they are not respected, nothing will happen. And I think that as we think about this system, we must go back and ask ourselves, what do we do to strengthen the human resources? And particularly, what do you build the human resources at the local level? No doctor will go to any village to live. No nurse will go there, most likely. And therefore, we must look at community resources and say, how do we develop them optimally? Countries like Rwanda change their health system, Ethiopia, because of those community resources. We have them on paper, but how do we truly empower them? How do we truly equip them? How do we truly support them to become operational and become successful? Medicine, technology, governance, information, finance, services. But at the end of the day, it's all about the people. And that's why I put that asterisk there. That a well-functioning health system provides a platform for ensuring and improving the health of the people at individual, household, and community level. And then we can begin to think about the result. Next slide. I want to begin to round up. So what matters? What are likely to be the game changers? Number one, if you take notice, I have put below those blue arrows, the basic things about that, very basic. Oh, we need to generate more funds. Yes, domestic funding from private sector. We need to draw more funds from all kind of partners. We need to shop for new partners. All that are important. We need to reduce wastages and ensure we are cost effective. But beyond that, those can only achieve basic results. They will not take this transformation to the next level. What are the things I think might take this to the next level? Number one, ownership and accountability at where it matters most, the community. When there is a health center in a community and the community people believe that is their own, nobody will steal drug easily. They will cut the person's head off if they think this is a facility. And so we must find a mechanism to get the local people truly believing in the system, part of decision making, and the accountability mechanism must include them. That is part of what we must do if we want this new transformation to truly take root and continue over time. Number two, Number 3, I've called this responsiveness, learning, and innovation. Intentionally put the 3 together. When I talk about responsiveness, I'm now talking about how do we understand our failure and make amends. One of the things I think that happens to us is I don't think we take enough time to step back and say, what have we done? Where have we failed? How do we respond to that failure? We run an agenda and say we want to do this for 4 years and then just keep on going, either it is working or not. I think we must pause, we must respond, we must learn, we must respond, and we must let innovation come from those lessons from what we have learned about our failure so that we can move from failure to success. And we must think, we must employ system thinking. We must make sure that our health leaders, our health workers understand what it takes to do system thinking. When I was a resident doctor, I used to be NME Secretary General in the state. And I remember at a point in time when they took our salary from MSS and took it out and put it somewhere else, I told my friend, I said, that this is chaos. Because if you increase the salary of doctors and you don't increase that of nurses, it's not system thinking. These nurses will go on strike. And so today, they will increase doctors' own. Nurses will go on strike. They will increase nurses' own. Doctors will go on strike. And that's when people need to have system thinking and think about integrating innovations into their system. Any innovation that is not integrated into the system will die. It's simply a matter of time. We must also think much more about what is this sustainability beyond word. What will it take? What do we need to put on ground to ensure that sustainability becomes the game of the future? I do believe very strongly that if you're able to develop a strong sense of ownership and accountability, we might be on our way there. I think I have 2 or so slides more. Let me go and I'll start. Beyond the health sector. There's high level of poverty. I'm sure many of us may have read directly or you may have said there are about 139 million people now poor. How are they going to be healthy? The first cause of ill health is poverty. A woman has the knowledge, I need to take my child to the hospital, but she doesn't have the money to get a transport. How's she going to get there? If you like, provide the best of services there. She can't get there. How is she going to use the services? An increasing level of unemployment, particularly among young people. And thirdly, the increasing and continued challenge of insecurity. Because that is leading to a lot of problems. There's poverty in the land. There is hunger because people can't go to farm. So we are beginning to see go on, don't worry. The reality is this: except and until we address these changes, no health sector reform will reform anybody's life in terms of health. It's not going to change the health of Nigerians. The Nigerians' health is not going to improve until we have a whole of government approach to health where we are looking at what affects us outside even the health sector. Next slide. I want to close with 2 slides. This is what our minister said at the conference in Accra in August, and I agree with him, that we cannot build either population purely on the generosity of other nations. It is time for us as a people, as a country, to define our own path, rooted in sovereignty and aligned with local needs. My last slide. It's nice to see the movement and the traction we are seeing. But the question is, how well are we building partnership? Where are we bringing others? Particularly where it matters most, at the community level. How well is the government partnering to truly engender that sense of ownership? Like it is said, the African proverb, if you want to go fast, go alone. Roll out all the program. But if you want to go far, we need to work together. We need to go with people. I want to thank you sincerely for your attention.
Keep clapping, keep clapping. Keep putting those hands together for Professor Fatisi. Wow. Wow. Thank you so much. Thank you so much, Prof. Thank you so much for that PhD professor lecture.
my notes is so full with the insights that have come. But a few notes from the keynote speech, and I want us to go back pondering on these. Will African governments allow the cycle of dependency to continue? Will the Nigerian government take these opportunity? And like the popular saying, in the chaos is the great invite. It may be chaotic now, but come on. It may be chaotic now, but if you look around, you see beautiful, beautiful opportunities. Thank you so much, Prof, for opening our hearts to see that. And then the last things he mentioned, the 4 key points. 1 on ownership, accountability, responsiveness, and learning innovations. And I'm so proud that we as CIHP, we have been able to build innovative hubs across Lagos State that have empowered hundreds of adolescent girls with tech skills and life empowerment. That deserves a round of applause. And we hope to take it a notch higher. Ladies and gentlemen, if you want to go fast, go alone. But if you want to go far, go together. And just like the Ubuntu principle, I am because we are. We have this beautiful opportunity in our hands. Let's take it and make the best out of it. A round of applause again. Permits me to, Professor Fatusi, sir, permits me to use this opportunity to tell this 1-minute story about Prof. I remember in 2014, I was just a young NYSC chap, and I needed clue on the next step to take. And I remember on the stairs at Obafemi Awolowo University, I saw Prof one morning, and I said, "Sir, I'd like to see you. I'd like to come have a word with you." And he said, "Be in my office Tuesday, 6 p.m. 6 p.m. Who gives appointment by 6 p.m.? That's Prof. That's Prof for you. And when I got back, I told my guys, I'm like, he said 6 p.m. I don't think he'll be there. 6 p.m. he was there. And I was there 6 p.m. And I said, "Sir, I'm about to round off NYSC and I don't know the next step to take. Could you please guide me?" And he brought out a textbook. And I said, "I'd like to pick up my forms in public health. I'd like to take a master's in public health program." And he handed over a textbook to me and he said, "This is what I can do for you. Go back, read this textbook. It's a textbook on tropical medicine by Professor Lucas Adetokunbo." And then I went back. He said, "Read this book from page to page, and then you pass and you get into the department." That's my department, by the way. I was like, "Oh, wow, that's your department. Thank you very much, sir." I went back home. I read that textbook. I read that book from start. My life depended on the textbook. I knew, because the next day I saw him and he asked me, "What's your CGPA?" And I said, "My CGPA, I'm not going to say it here." And he said, "Go back and read that textbook. Your life depends on the textbook." Sir, I went back, I read the textbook, and to the glory of God, I topped that class. I became the class rep, and he was my lecturer. Thank you so much, Professor Fatusi. I like to say that seed you sowed has grown, and it's still growing. Thank you so much. God bless you. Ladies and gentlemen, a warm round of applause again for Professor Fatusi. All right, we'd like to recognize some dignitaries who walked in. We'd like to recognize the presence of the National Primary Healthcare Development Agency, the Assistant Director of the National Primary Healthcare Development Agency, Mr. Taiwo Adebisin. A round of applause for Mr. Taiwo. The next on our agenda.
We'd also like to recognize the presence of Dr. Lillian Anomnachi, the Executive Director, TA Connect. We at CIHP are proud to have a long-standing relationship with you. Thank you so much. So we also like to recognize the presence of Dr. Samson Ezekianyi, the Team Lead Health Systems, UNFPA.
Thank you.
Also with us is the Country Coordinator, ICAP Global Health Initiative Nigeria, Dr. Remi Abiola Oladigbolu. Welcome, sir.
All right. that my story was just to emphasize why, while I was reading his bill, I was so emphatic about the great and prestigious Ife. All right. So the next on the agenda is a poetry session by Zainab Mohammed from the Spoken Word Artistry and Crafty, a development advocacy organization. Ladies and gentlemen, put your hands together for Zainab Mohammed as she takes the stage.
Good morning, distinguished guests, ladies and gentlemen. My name is Zainab Tijani Mohammed, and it's my honor to recite this poem titled "To Keep This Heart Beating," and I hope it speaks to you. Okay. On the day she died, there was turbulence. The news hovered like a bird trying to find its resting place, because her story did not end there. 1 minute she was here, pregnant, lived a double life for 9 months only to be ripped off the calendar. Gone, too late. Maybe she could have been saved. But complications don't always come from the body. Sometimes it comes from the system. Complications don't always come from the body. Sometimes it comes from the system. She bled her own name in her own screams. The system failed her. So today, there was no room for tears, just survival. And even that felt like an extracurricular activities where lessons were never taught. So for her, I stand. For every woman who went to the hospital and did not return. For every family whose grief could have been prevented, see. It's easy to wrap a body in white than to fix the light in theater rooms. It's easy to promise change on reports in paper, see. We've been here long enough to recognize tragedy in the blink of an eye. We have watched victims rolled out of emergencies with no urgencies. We have seen doctors press fate to their chest because fate was the only tool they had left. We have seen death come from the absence of oxygen, not illness. We have seen too much. But grief is not where this story ends. So today, let us reimagine. Not just dream, let us reimagine. Let's do something different. Let's innovate. Innovation is access. It is making sure solutions arrive at our doorsteps, not just for those who can afford to leave. Because of what use will it be if those who need it the most cannot reach out for it? And quality is not just about survival. It is being treated as a human being. It means knowing that fear will not meet you at the hospital door when you go knocking on it. Let us own this story. Let us write the policies. We lead the systems. We decide the future. No more waiting. This is our home, and we hold the pen. And sustainability, it's how we want our future to receive us. To stay alive requires more than breath. It is the water we consume. A system that stands strong and fuels us like an Iroko tree. So we move, we innovate, we create, we refuse to stay stuck in a box. Something phenomenal sits in our thoughts, in our hands. Our story is ours to build, ours to keep alive. This is our bed. Let us build something strong so we do not cry tomorrow, so we do not go to sleep with fear in our eyes. And home is where the heart is. So let us, or we will do all we can to keep this heart beating. Thank you.
Thank you, Zainab, for those words. So just to get us primed for our first panel session and discussions, we are going to have a little trivia where we just let us know in one word, what does innovation, one word or phrase, what innovation means to you all. If you check the back of your program, you would see a QR code, or you log on to menti.com and use the code on the screen, 7838-7488 to log in, and just put in your thoughts on what innovation means to you. So the panel discussion would be on innovation and ownership, the future of health systems, pathways for Nigeria and beyond. So quickly, please, let's just put down what innovation means to us.
All right, just if you're having difficulty scanning the QR code, we have the number that you can also use to access 90 meter. Okay.
So we have one word there, future. We need more.
Okay, Dr. I think Pamela is here to help us, to guide people. Yeah.
Okay, good morning, everyone. Please just go to menti.com. You see this code here, 78387488. You can also check the back of your program guide. The QR code is there. You can quickly scan it and let the responses start coming. So we have rethinking. People are already sending in their responses. We have creativity. We have future. We have simple solutions. So let the responses keep coming. Okay, change is going up. We have Jackpa. In one word. So innovation means Jackpa. Okay. We have novelty. We have trailblazing. Wow. Okay. Novel. Building. Simple solutions. Okay. That's interesting. Way out. Okay. Okay. I'm seeing power. Wow. Power. Okay. Let's keep the responses coming.
Okay, just in case you're yet to scan the QR code, is on page 27 of your program. Page 27, you'll see the QR code there. Thank you.
It's at the back, page 27 is at the back, where you have the thank you. Okay, responses are still coming. So innovation means progress. It means new. Novelty, way out. Power, new, creativity. I think that's becoming bigger. We have change, and then impact. Rethinking, results. Interesting. Okay. It means progress. It means solutions. Okay, there is another question anyway. So I think when we have enough responses, we just move on to the next question. So the panelists will do justice to this. So the next question, please.
Next question, please.
Okay, so the question is up. What is the major barrier to health sustainability in Nigeria? So we're still going in the same order. You use the QR code. If you're already there, you may not need to use the QR code again. So the responses are already coming. So this one says funding, poverty, solutions. Okay, corruption.
Corruption. Wow. Someone said Osusu.
Okay. Our government. Wow. Okay. The people, lack of ownership. Osusu. Okay.
Osusu.
Osusu.
Sorry, Osusu to our international audience. Osusu means Osusu.
Okay, we have policy. So the question is, what is the major barrier to health sustainability in Nigeria? And these are the responses that are coming. So you can continue to send in your questions, your responses. So we have ownership, we have continuity, we have the people, okay? Lack of ownership, funding, and another funding. Implementation, continuity. We have funding again. So we've had funding like 3 times. We have corruption, we have poverty, we have our government commitment. So I believe the panelists will do justice to this. Thank you very much. You can keep the responses coming, actually. Thank you.
Thank you, everyone. So we can see that he's already on his feet. So to moderate the next session, it's my pleasure to welcome Dr. Chris Obanubi. Dr. Chris Obanubi is a global health strategist and CEO co-founder of Indigo Global. With over 20 years of experience, he is a health systems expert who designs integrated country-led solutions across Africa. His work spans HIV, TB, primary health care, and pandemic preparedness. He has provided strategic direction to major multi-country portfolios with the CDC, USAID, and CIHP, strengthening institutions and promoting sustainable, locally driven service models. Passionate about digitally empowered and equitable systems, his leadership focuses on integrating technology and evidence into national strategies. Through Indigo Global, a Southern African startup platform, he advances AI and digital innovations to transform health, education, and economic system. Dr. Chris Obanubi is no stranger to this house. Ladies and gentlemen, please welcome Dr. Chris.
Keep clapping till he gets to his seat. Please don't stop till he gets to his seat. Give it all for Dr. Chris. All right, thank you. So the next panelist is Dr. Kunle Kakanfo. He's the lead strategy, growth and influence managing partner, Africa Hub for Innovation and Development. Dr. Kunle is a distinguished public health physician, a global social impact expert with approximately 15 years of experience. He specializes in strengthening health systems through data-driven strategy and digital innovation. His significant achievements include leading a multi-country digital transformation for nutrition programs across Africa and Asia, and dramatically scaling up a major PEPFAR HIV initiative in Nigeria. He led a strategic program that successfully increased antiretroviral treatment coverage from 20% to 80%. That deserves a round of applause. He is the founder of AI for SID, creating an innovative AI-powered cough analyzer for TB detection, a seasoned project manager and fellow of multiple academia. He uniquely blends high-level strategic advisory with technological innovation for social good. Ladies and gentlemen, Dr. Kunle Kakanfo. Put your hands together. Please keep clapping till they take their seats. Thank you very much. Thank you very much.
Also joining them on stage is Dr. Folakemi Amina Shaun. Dr. Folakemi Basirat Amina Shaun is the CEO of Lagos State AIDS Control Agency, LSACA. She is a distinguished medical doctor and public health leader. Holding an MBBS, MPH, and MBA, she began her career in Lagos State Civil Service in 2010. Previously, she coordinated health screening, managed emergency services, and provided policy guidance in various ministries. Since leading LSACA, she has expanded HIV services to over 1 million residents, integrating them into 90% of healthcare facilities. Dr. Amina Shaun champions mother-to-child health transmission, prevention, community advocacy, and partnerships, aligning Lagos with global AIDS eradication goals by 2030. Her visionary leadership drives equitable, data-driven health governance. Ladies and gentlemen, Dr. Folakemi Amina Shaun.
Please keep clapping till they get to their seats, ladies and gentlemen. Thank you very much. Also joining the team of wonderful panelists is the Executive Director, the International Research Center of Excellence of the Institute of Human Virology, Nigeria, IHVN, Professor Alashe Abimiku. Professor Alashe Abimiku is a co-founder of the Institute of Human Virology, IHVN, and Executive Director of its International Research Center of Excellence, and a Professor of Medicine at the University of Maryland School of Medicine. With over 30 years of experience, she is a distinguished academic and scientist who has pioneered quality laboratory medicine and research in Africa. Our key achievements include first documenting the unique HIV subtype G prevalence in Nigeria and establishing the first reliable HIV research lab in central Nigeria. As a principal investigator for numerous major funders like NIH and PEPFAR, she has and continued to pivotal in fostering long-term international research collaborations. Ladies and gentlemen, Professor Abimiku Alashe.
Also joining us on stage is the managing partner and CEO of Polyone Consultants Limited. Dr. Oluwole Odutolu is a public health physician, global health and development expert, and a public policy entrepreneur. He currently serves as the managing partner and CEO of Polyone Consultants Limited, UK. He retired from the World Bank Group in 2022, where he served as senior health specialist and results-based financing coordinator within the Health, Nutrition, and Population Group Practice and Global Financing Facility. He led multiple innovative healthcare delivery projects targeting primary healthcare and reproductive, maternal, child, and adolescent health with a focus on service delivery, promoting accountability, reducing social inequalities, and improving health outcomes for children and women in marginalized and underserved communities in Nigeria and other countries in the African region. He is published very widely in peer-reviewed journals, co-edited 2 books on AIDS in Nigeria, and contributed chapters to books. He has continuing interest in human capital development, social policy, equity, and financial inclusion. Ladies and gentlemen, please join me in welcoming Dr. Oluwole Odutolu.
Okay, Dr. Oluwole will be joining us online, and he's in the UK currently, and then he'll be giving us his feedbacks online. So, ladies and gentlemen, to lead the conversation for this session is no other person than Dr. Chris Obanobi. But before we hand over the mic to Dr. Chris, we'd like to recognize the presence of the Honorable Commissioner for Health, Rivers State, Dr. Adeze Ore. You're welcome, ma'am.
Also with us today is Dr. Charles Mensah, the MD CEO, Institute of Human Virology, Nigeria.
The floor is yours, Dr. Chris.
All right, so thank you very much to our wonderful MCs. Can we give them a round of applause, please? All right, so today's topic and setting this session is on a topic that resonates very deeply with me, and that's on innovation, but on ownership. And I think Professor Fatusi has really set the tone. So to our online community, to our participants here, to our CEOs, to the co-directors, and to the change leaders and the leaders in change here, I just want to say welcome. Once again, I'm Dr. Chris Obanobi, and I'll be moderating this session with a great panel of experts here that have over 100 years of cutting-edge experience. I'm expecting to hear something for that. All right, and the reason why I'm setting that tone right now is because I think the odds are very clear. Right now, we have global shifts and global headwinds that are very clear to everybody. And ladies and gentlemen, in the next 5 years, when we look back at this moment in time in terms of the history, nobody's going to be asking about what happened to the donor funds. Everybody's going to be asking one singular question, and that is, what did Africa do? The most singular question everybody's going to ask is, what did Africa do? And we're going to ask the question, what was our response? What did we build? And so today we're going to be setting a tone, and we'll be starting with Dr. Kunle Kakanfo. Innovations. Okay. In terms of innovations, we've seen innovations that have really transformed the landscape in the last 10 years. donor funding has really helped propel innovations in service delivery. We've seen innovations in health financing. We've seen innovations in logistics. But right now, it's not those innovations that were at the startup phase that we're looking at. What we're looking at is at the subnational level, as Professor Fatusi said.
Hello? Okay, great. I hope you can hear me. It's just that I might need to bend down a bit. All right, so what we have seen right now is that in terms of innovations, we have innovations at the startup level. Some of them have gotten to the scale-up level. And we have some maturation enterprises that have shown innovations. But what we're asking right now is that are our innovations going to take us from here to there in the next 5 years? Are they going to transform and build those health systems? We saw some very damning statistics. And so, Dr. Kune, just to really ask of you from the insights, I know you're just recently back from Rwanda where there was a conversation about transforming health systems. What is out there in the four corners of sub-Saharan Africa? What is out there in Nigeria that we can elevate? What are promising innovations that you can spotlight and put a green spot on that you think that we can take to scale? We can domesticate, we can own, and those will transform the health systems. Because we really want to see a change. We don't want to get stuck in policies, and we also don't want to get stuck in shiny initiatives. So, Dr. Kune, over to you.
I'm sorry. I feel a bit shocked that Chris is calling me first. When Prof, like I feel totally lost right now because I really don't know how to set the stage. I didn't plan my script to set the stage. I planned my script to follow through with people like Prof. So I'm sorry if I have gaps in my conversation, but I think the concept of innovation, to me, first of all, we need to demystify how we look at innovation. Most of the time, when we talk about innovation, we talk about one new shiny thing. Just like Dr. Chris has already started to say what is out there. There's really, really nothing out there. There's really nothing out there that have not been known before, that have not been used, that have not been in the minds of people. So for me, I think we should just come back a little bit. And the current problem that Prof had really broken down, in my own personal opinion, it is not a question of leadership or resources. I think we have moved too fast beyond where we are as a people. Our programs have moved too advanced beyond where we are as a people. And those are the kind of resets we need to do. First of all, we have capitalized our programs rather than driving them with the people who need them. And when I say capitalized, we have invested the kind of infrastructure that we cannot necessarily afford or continue to sustain. And remember, I said my personal opinion. But coming back to the conversation that we're having, how do we reimagine health systems? How do we use innovation? And this is where I'm going to start from. Prof had really laid a very solid foundation. I wasn't taking notes. I was taking pictures of literally everything Prof had on the screen so that I can go back and tell my AI to give me a full, comprehensive detail of what Prof have said. And coming back to this discussion, we would begin to look at all the different pillars that should drive how we reimagine the health system. There are currently things that we do. There's a lot of shiny elements at the national level, I must say. And that's why this conversation, I would ask that we take it home. We drive it down to subnational level. Recently, I had conversations with some key stakeholders. I won't be able to go into all the details. And the conversations are really very simple. We know where the direction is going in terms of global health systems, global health strategy, and those are like the driving force that have driven Africa health systems. We cannot suddenly withdraw them or take them away. We need to see how do we complement this global health strategy. So for example, the US global health strategy had laid certain things out. And because it's a major driving force, whether we like it or not, that's where we are. That's the sophistication that we have embraced, and that's why I said we have gone way too far beyond our level as an economy, as a country. So what it means is that if we're looking at what the Global Health Strategy is trying to do, the Global Health Strategy is trying to go into a different way of doing business, using private sector and using government to government. The key emphasis will be government to government. That means that government given the reins of control of everything. And from where I stand, having been a little bit part of the system, and in the corridors of some of this information, it's real. Government to government is real. And whether we like it or not, it's still going to shift how we are going to be reimagining health systems. One, because resources will drive it. The people will drive it. And because the resources are going to be driven in a different direction, that means that our reimagining health systems has to go, we cannot eject ourselves forcefully from this approach. We have to transition it and taper it slowly. So if we're talking about government to government systems, that means the kind of innovations that we should be talking about, what are the innovations that can drive and support a government to government system? And looking at this room, we have pretty much those of us who've been working in the social sector, due respect to our government representative. What's going to be our own positioning in terms of how do we innovate through this new phase? And I think that's where the question of innovations become more granular. What do we need to do to position, first of all? What do we need to do to support government-to-government systems? We're not even going into private sector handling first. And the global health strategies unpacked it. I talked about use of data, use of digital systems, existing ones, and the new ones. So how can government use data, use digital systems, use digital platforms to make this whole process of streamlining funding through the government easy? I'll give you an example. When the aid was forcefully removed in January, then everybody was scrambling for information. And our team came together and pulled together, because of some of the data we had, opportunities to have the number of persons that are being engaged by PEFA, by partner, by state, and all of that. HRH basically, and all the commodity data. So we put it together and we costed it also based on some traditional resource information that we have. What amount of money would it cost to fund what PEFA had been funding through CIHP, IHVN, and all the partners. And we put it out together, and we did a modeling with it saying that this is what it's going to cost the government for the next 6 months. This is what it costs per day, and this is what it's going to cost the government for the next 6 months. And we shared with NASCA. We did it like, unsolicited, but what's important is that they did not have that information before we shared it. They were scrambling for the information. So we put it together and we modeled what it would cost and what it would cost the respective state government per year. And looking at this information, we had a meeting with NASCAP and they took it forward. And one of the things that became more important, we also shared with NACA, sorry. One of the things that became more important is that this kind of resources, can it be afforded by government alone? How can we use the data to steer how we shape these reimagined health systems? Because these are the critical pillars that have kept the health system running, whether we like it or not. So how can we innovate using data, continuously using data? And there's an emerging need now. Now, the all compact discussion had happened, and the emerging need, and where I was going with this conversation is, states are looking for, okay, what do we need to invest? We only have XYZ amount of money. We're beginning to work, and we already set up a prototype of a model that says if you're investing 20% of this amount of money, not just into one program, not into HIV program. And I think the whole reimagining concept, that's where it drives us to. Our innovation, our innovative capabilities has to be highly integrative. Even as vertical programs, we need to begin to think of it in a very integrated manner. So we said, okay, let's pull together HIV, TB, and malaria. And in discussional phases, we have a model that shows if you invest 20% at the state level into HIV, TB, and malaria, this is the amount of coverage it could get to. How did we do that? We did that because we used the power of data, We use the power of technology, AI of course, and we put together a couple of impact modeling. We didn't have to do calculative impact modeling in a mathematical way as it's been done. We used AI and all of that to do it. And the discussions are going on to say, even at the local government level, if they invest just 5 million naira, what would it cover? So that model is able to, and it's an open dashboard in discussion and early stages, is able to say, this is what we need to be able to drive and help us reimagine our health systems. And I'm talking about innovations. There's still a lot to talk about. What key innovations can we use in the days to come to simplify health systems? Now, everybody talks about tax shifting, which is probably the frontier of how to make sure that we reduce the burden on the healthcare providers. One of the things that we're doing, and in a global fund discussion on how to use AI for health, was a roundtable to say, how do we direct our funding in a couple of weeks? One of the things that was key, and we put to the table, is that how can we use AI to unpack tax shifting? How can we bring the necessary tools that make sure that the low-skilled healthcare workers can use AI tools? And there are a couple of them that we are currently experimenting and working on. We have an AI-powered cervical screening tool that just enables the healthcare worker to take a picture. Any healthcare worker for that matter, it doesn't have to be a doctor, to take a picture and is able to interpret whether it's a cervical cancer lesion, and also help to guide that low-level healthcare worker with decision making. How much more can we try to implement tax shifting? We also have an AI-powered cough analyzer that we developed. We currently just got the blessing of the national TV program, and we've tapped on a lot of subject matter expertise from across board, especially from IHVN, to develop it. The AI-powered cough analyzer just allows the lowest cadre healthcare worker to hold their phone and hear you cough as you come into the facility. It triages your cough, tell you your cough is supposed to be TB or otherwise, and enables the highly skilled medical doctors to have less to do. I'm just trying to keep them in simple terms. Tax shifting at its best, because we talk about tax shifting and we try to force a number of skills on those low-cadre healthcare workers, when we can as well automate those skills and help them with tools that can help them with clinical decision making. I'll stop there for now, Dr. Chris. You took me unawares. I'm sorry my thoughts were all over the place.
No, I think he did a really great job. A round of applause for him. I actually did have a follow-on for you, because they're really interesting the way how you spoke about AI. I think it would be nice, and then tying it to what Professor Fatusi said, is there a way how we can scale up some of the solutions for AI at the subnational level? All right, and then how low can you get to? And then what are the possibilities there? Because right now you've already identified a gap. One of my mentors has said you always innovate in abundance. And abundance right now is that you have a shortage, right? So how do you use AI at that subnational level? How low? And then what's the limitation as well?
So interestingly, one of the reasons why we went the route we went, sometimes it can be slow, is that we wanted to make sure that it was a national TB program that was leading the frontiers of the solution we're building. And the same thing for the cervical cancer one. We wanted to make sure that the national cervical and the national cancer program was leading. We have one of the subject matter expert nominated, Professor Dean Cyril, who is also leading the front for that. Because we want to make sure that as we deploy these tools, or support the deployment of these tools, and for all that, in terms of our model, these tools are developed essentially for social good. The organization that I lead to run most of these, where we just set up an AI hub for social impact and social good. All the tools we developed are essentially developed for free to be used back in the community. That means that it's going to be low cost. And the thing about, and when we were comparing some of those tools, they are all low barrier tools. They are not tools, you don't need to buy a digital X-ray machine to be able to get explainable AI out of an X-ray, when you can use a phone you already have with an app you download for free and just enable you to be able to make diagnoses for TB. The same thing for cancer, cervical cancer, and a whole lot of others that are currently in the pilot phases. And so one of the things we're doing is to make sure that government owns and leads it. because it's not going to cost anything for them to do that. And then as we finish through the first phase, with AI also, there's still a lot of limitations right now. And if you let me loose on AI, I probably will not stop.
Right.
There's a lot of limitations. I need to say this so that we can balance the context. A lot of limitations because currently in Nigeria, we do not have the right guardrails, the right frameworks to deploy AI. So what we do is to go through the ethical research route. And we're currently working with government to make sure that we can drive the process of developing those frameworks that AI in health has to be guided by validation protocols and not necessarily driven by research or pilots all the time. And I was fortunate to be in a small meeting with the president of Makoto Foundation where they were looking at the kind of investment we need to put into AI a few days ago, and that's one of the key things that they're talking about. And we cannot also do without resources. Thank you. I'm done.
All right. Thank you very much. So I think that was very insightful. He spoke about intelligent systems that are integrated at the subnational level. We've seen that in Rwanda. We've seen that even in Singapore. We've even seen that in some Southern African countries where they're using AI at the subnational level, and that's really increasing efficiency. But what we're also seeing in terms of these innovations, Dr. Anima Shao, what we're also seeing across these innovations is that the secret ingredient for innovations that have worked across Africa has been them having community at the epicenter. So community is at the epicenter, community is connected, community is co-creating, community is also co-engineering, and then with that we're seeing sustained impact. Now bringing it home down to our beloved Nigeria and elevated Nigeria up, with some of the innovations that Dr. Kakanfo has spoken about, some of the innovations that we're seeing across the sub-Saharan Africa landscape, how do we ensure, Dr. Anima Shao, that these innovations are connected? And let me take it home. Let me make it personal. If you're anything like me, you probably have over 300 apps on your phone, maybe more, maybe 1,000, who knows? But of that 1,000 which you thought had use, there are probably just 10 or 20% that use the most. And those are the ones you're connected to. And so I'm asking right now that it's great that we have a lot of these innovations. Quite a lot of them are shiny, some of them at the startup phase, maybe not enough at the scale-up phase and maturation phase. But how do you make sure, Dr. Anima Shao, from your experience, from the incredible work you've done in one of the arguably most innovative states in Lagos, how do you make sure they're connected, one? And then how do you make sure that in terms of the beneficiary, it gets to the end user? Because we don't want to have endless policies. We don't want to have endless solutions that at the end of the day, when you look at the reports, we're still down there in terms of the bottom 5. Over to you.
All right, thank you very much, Dr. Chris. When we speak about innovation in health systems, Dr. Kankafo, permit me to say that we often celebrate technology, we'll celebrate research breakthroughs, and so many delivery models. But the truth is, innovation is not sustainable until it is owned, until it is understood and championed by the community that we serve. So, on the other hand, when we say sustainability does not start in laboratories. It does not start in these boardrooms that we have. It starts from where people live, where they're going to learn, and where they're going to take ownership of what we're building for them. Innovation is not just about ideas or technologies. It's actually something that we need to build into trust, accountability, because the people that we serve at the community need to be a part of innovation, not just a beneficiary, but the owner of this thing. So in Nigeria, I would say that we have no shortage of innovation. Just like Paul said, that we have so many policies, we have so many things that we sit there in our boardrooms to talk about. But we lack sustainability of all these things. We have the capacity of for these innovations, for it to be maintained, for it to be scaled and to be honed. I'll use Lagos models as some of our examples of some of the things that we've actually involved our community with. I think Prof will need to permit me to say that in Lagos, we actually work with the traditional birth attendants. Maybe because the way Lagos State is structured, or maybe because the cosmopolitan settings of Lagos State. So when Prof was making that presentation, I was just smiling. I said, I'm going to talk about traditional birth attendants because Even the educated people still patronize this TBAs. So in Lagos State, we have the Lagos State Traditional Medicine Board, who actually regulates what they do in order to ensure and avoid quackery. Because the honest truth is, we can't overemphasize the number of populations or the number of Lagosians that actually patronize these people. So what do? There's a Traditional Medicine Board who regulates their affairs, who regulates what they do at the community level. So at the Lagos State AIDS Control Agency, again, we ensure that we train them for them to ensure ownership of what they are doing at the grassroots level when it comes to HIV response in order to reduce maternal and child mortality. So it means that when a pregnant woman comes to the community, one of the things that you do for them as part of their routine investigation is HIV test. So when you see an HIV positive woman, it means that you have to refer this set of people. So Professor in Lagos State will still do traditional birth attendance, and it's something that it's important because they constitute a very large population, and if we have to leave them out of this population, then it means that we are leaving a large portion of people that is still going to affect by maternal mortality.
And is it working?
It's working effectively because we've called the board has actually covered a lot of people, and they're able to reach the rural area where the health to access is quite low. Yes. Also, part of our community engagement, we partnered with the Women Affairs and Poverty Alleviation, like our interministerial collaboration in Lagos State. So Women Affairs Poverty Alleviation, we know that they do a lot of empowerment in Lagos State. So we tend to integrate our PLHIV networks into their system. So it means that even when they're out of job, because yes, we are still fighting stigma, we are fighting discrimination, and then some of them, they tend not to go back to their workplace, even when we are able to mediate over, which I will talk about gender-based violence and HIV intersection that we do. So in this regard, we ensure that our PLHIV are being empowered and they take ownership of whatever we are doing at the community level. In the same vein, we've also engaged and partnered with the traditional rulers in the state. So yes, traditional rulers in the state to ensure that they are ambassadors of our HIV response. That means that in every community, we know that we have a royal father in that setting that is actually educated people the way we've educated them, the way we've actually empowered them with knowledge when it comes to HIV. And at the same time, our traditional, our religious leaders, we've ensured that they are using their platform to discuss about HIV, to dispel myths and facts about HIV. Chris is giving me time, so I think I need to stop there. Thank you.
No, I think that was really interesting. A round of applause for her. So if there's any take-home I'm getting right now, it's decentralizing intelligence at the subnational level, number one, but making sure that your solutions are not just limited to data solutions, but also connected to the community. Am I correct?
Yes.
And then innovate shamelessly. Whoever's out there, innovate with them. Whoever's providing support, whether it's the traditional birth attendants or anyone else that's providing from the non-formal health sector, innovate with them, maximally, and you're going to get some of the gains we're looking at. So really great to see that Lagos is a bright spot and a shining light, and it would be great to see how we can replicate that across some other states. I'm just curious to know, Prof, that over the last decade or so, especially with donor funding, we have tons and tons of data that's out there. You have program data that's out there, you have research data that's out there. And what we're seeing right now across sub-Saharan Africa is that there seems to be a super gap, a no-do gap, where over 70% of that data that we're generating, I like the way how Kunle was able to use some of that data intelligently. A lot of that data is not used in that way to create efficiencies and create effectiveness. And I'm just wondering how, with the wealth of experience that you have, that you bring on board, that you've done as a partner and also across the nation, how can we ensure that we are scaling up research and evidence to become scalable policies and practices? And beyond scalable promises and practices, how do we now take the biggest and
And the biggest leap is where policies become implementation, and implementation drive results. So I'm curious to know, how do we bring all of this and tie all of this together?
Give another
Prof.
question. Yeah. No, thanks very much for that question. And it's really been a riveting morning. I've learned a lot. I really commend our keynote speaker and our host, and of course, our lead in HIV, the DG. She's always there. We've had our scientific symposium for 2 or 3 days. She's always there encouraging us. But not only that, I can tell you that we've had great success in putting together grants that she is sitting there. We're designing the specific aims, implementation, and everything. And one of them is the NIH PEPFAR coalition to set up implementation science in terms of what we do. So thank you. I heard a lot that's really very helpful. I heard about partnerships, and Bola talk about revitalizing even the ones that are comatose. I heard about equity, innovation, efficiency, sustainability, and holistic, looking at our system holistically. And your point is really the bedrock of how we can move forward and apply research in a way that it can support us. How well have we done as a country in terms of data, right? Whether you're going to do your research, whether you're doing task shifting, whether you're doing health system strengthening, whether you're involving AI, it's all dependent on the data that you acquire and how good and accurate that data is. So I think fundamental to what we are doing as a country, we must have data. It must be possible to go to a website, look at the data, and be able to really believe in that data and know that this is where we are as a country. I think Prof. Fatoussi in his keynote address said, maybe this is a time for us to step back and go to the rudimentaries. Can we, at every structure and every activity we have in the country, establish the ability to collect good data that we can really trust? We can flash it up in a minute. Yes, we have limited funding. We have the data that says, okay, you did a lot of work to look at how much it's going to cost and everything and do a modeling to inform government. But it should be possible for us to say, well, this is how much external funding we're getting in, and this is the gap that we have to address. And this is what funds we have, but this is, and this is where it's going to go. So research in terms of informing whatever we're doing in terms of implementation is absolutely critical. But the bedrock of research is quality data. We have to make sure that every single thing we do as a country has data that folks can go to and really be able to look at how we're doing. I just wanted to give some examples. I mean, I believe that during the discussion there was the point that we as a country cannot live in isolation. It's the same thing with research, that we have to understand what is going on globally and that the research we do is at international standard. We're not doing research because we're doing it for Nigeria to be consumed locally. We're doing research that will go internationally and inform. So all of the standards, everything, the building blocks that we need to put in place has to be at international standards. And we have to pay attention to our young researchers and really begin to involve them in everything that we're doing, mentor them. Let them bring their research questions. Let them bring the things that they're observing. So I believe that that is really critical in terms of forming the partnership. And the partnership,
you've all talked about the role that communities play. But communities should not be at the time that we want to disseminate whatever findings we have. They should be at the table. Exactly. This is what we're thinking of doing. And just for IHVN, I can tell you that significantly, we really appreciate our board members. And if you have any question in terms of how much the investment has cost IHVN, Dr. Mensah will gladly answer that. But I can tell you that one of my attractions, after staying in the diaspora for a while in Maryland, University of Maryland for a while, one of the attractions that brought me back home to build the research enterprise at IHVN is really the infrastructure that the institution invested in. So there were core laboratories, there are biorepositories, the molecular lab, genomics lab, immunology, virology, at international standards. And in fact, some of the labs are much better than the ones that I work in. That really brings back your talent, okay? And when the government is, you know, one of the things that we have to believe in is breaking out those silos and ensuring that every resource within the country belongs to government, whether it's academia, whether it's NGO, whether it's laboratories and all of that. So anyway, I was talking about infrastructure, and that is a really great quote, because if I want to do research, I like to have an environment at international standard that can really deal with that. So in rounding up, I just want to touch on 3 funding that we have, just to give you an example of what I'm talking about. I already talked about the LASON PEPFAR funding that we got, that is a collaboration with government. So what is the focus of that funding? The government has set out a policy that they're going to roll out at primary health levels, you know, and they're going to have integrated disease management, HIV, TB, non-communicable diseases, cancer, and everything. What we're doing is setting the building blocks that will say, well, what was in existence and how have we improved it and how has it delivered results, like Professor Fatou Cissé. That is something that we've come together, community, government, and academia, to put that whole thing together to implement. The second one that I'm going to talk about is another funding that we got that says, in terms of pandemic preparedness, can you use the data you have in country to inform you of how did you manage COVID in terms of its transmissibility in all of the waves, and in terms of the interventions that you have put as a country? How effective was that in managing the different waves? And how does social vulnerability, in terms of your poverty level, how has that impacted your ability to respond to COVID, whether it's mask, whether it's social distancing, or whether it's taking the vaccine? Okay, we use the national data from Nigeria, national data from South Africa. And I can tell you that in terms of responding to all of those things and finding what we can do to better prepare for the next pandemic, there were holes in analyzing our data from Nigeria. We could, although we had data in terms of here's the infection and there's a lot of modeling and a lot of overlay. On the other hand, the one in South Africa significantly answered everything that we put. So we've identified gaps from that, and we really have to work together to begin to ensure that we have data that is high quality to the individual level, but protecting the individual, that will allow us to answer those questions. Thank you.
All right. Great. Thank you very much for that. I really like the way how she was able to tie research into evidence and how evidence at the lower level is actually driving actions and solutions. I think that's really great. I'm just curious to know, and you don't need to answer this now, maybe when you're closing, it'll be great to see how can we really bring that research down to the community level. So you have community research intelligence going on there, and how can you democratize it? And then recently it was all over the news how Deloitte got sued by the Australian government just because they produced a report for the Australian government using AI. But unfortunately, the models that were training the AI, didn't really fit the context of Australia. And it got me thinking that how many of the AI models do we have here in country? Are we using our big data to train those models? And is there an opportunity with, IHVNs and, the other big players in this room right now that we can use some of our data to train the models so that, they fit our context much more specifically and they're more tailored? So you don't need to answer that now, but it's a conversation that we have later on. So ladies and gentlemen, we've spoken about intelligence, we've spoken about community connectedness, we've spoken about research. But there is one big question that we haven't answered, and I'm going to really just take a quick poll. How many of us here think that the biggest problem in the room is finance? I do. Domestic finance. All right. If we do all of this work right now, we don't have to finance the power aid. How far are we going to go? And we have online with us Dr. Odosulu that will really be talking about how can we ensure we have the DNA of ownership in our innovations, in our community work, and our research. How do we ensure that, and recently, just last week, I joined a meeting in Durban where they were talking about financing, and they're coming up with some really bright ideas. One thing that struck me was the fact that they said that there's a shortfall of $12 billion. So I was excited coming in country when I saw that in country, the coordinating minister wrote an open letter. How many of us saw the open red letter? We saw that open red letter, which was a great initiative to see how we're beginning to release fundings to the lower levels. But the question is, how do we ensure that the community innovations and the innovations right now that are going to drive the transformation, how do we ensure that there's ownership of them? How do we ensure that ownership includes local leadership, local financing? How do we ensure it also includes the infrastructure and institutions? So Dr. Otuzulu, I really would like you to really go over how do we ensure that what we're building here is not something that is still very donor dependent, but it's something that can last and be resilient outside of donor funding cycles. Thank you. I hope you can hear me. Oh, great. There you are. Can we unmute him, please? We can't hear you yet. Can you try again? I think you're muted. Tech team, can we please kindly help him? You might be unmuted, sir. Yep. We can hear you now. Go for it. Yeah, we can hear you now.
This roundtable, technical roundtable, and also want to thank them for the work that they are doing. Looking at it in the context of CIP, AFP, IPF, and all the collaborators that have been, doing magnificent work with regards to HIV/AIDS in Nigeria. I think the idea of innovation is not new to that group. I was part of that group over time, and I know that there has been a lot of innovation that has been carried out over the years that has resulted in the results that we are seeing today. Before I come to specifically answer the question, I'm asked to look at this, from looking at national policy framework and stuff like that. But having listened to Dr. Fadusi in his keynote address, and lastly, before me, I was almost curious into going in another direction, but I was still staying. Within what I've planned to do before, and look at innovation as being specific to health, and innovation specific to technology-based entrepreneurship. But I will stay with innovation that are specific to health, and speak from experience. I'm not relate from the groups or academic, but I will speak as a public health practitioner, and what has happened in Nigeria over this period of time. I chose a period that are called the Golden Decade of Innovation in the Nigerian health system. That is between 2010 and 2020.
getting warmed up.
That's why I find it difficult to say that Nigeria is going to be dependent. Donors are in some special programs and they bring a lot of money into it. But over the years, and the donors have said, donors have not given up to 10% of what we spend on health in Nigeria. It's usually between 5 and 6%. But I agree, they are well spent in an area that is useful for all of us to see. I see that in a country where we have 70 to 75% of out-of-pocket expenditure, it's not that there is no money for health there, but that the money is not widely used, preserved, collected in one way or another, and made use in a way that is functional, in a way that also improves the health system of the country. Out-of-pocket expenditure is the most inefficient way of financing health, and that's what we are doing. And that's why we have to go back and see how we turn the out-of-pocket expenditure into something that is programmatic, something that goes, for example, into insurance and one thing or the other, but that's, I know some programs will struggle because they don't continue, but I think at the end of the day, it's how we better manage the resources that are coming to help on the population itself, and the government should increase the money that is spending, that is budgeting and spending for health. Let me come back to the policy framework that I was asked to talk about.
Please do.
See, for innovations, usually we have this policy-oriented framework for responsible innovation in health. I'm quoting Pastor Silva and his book on the work that they have done, where they have 5 delays. Population health, the health systems, economic, organizational, and environmental. I mean, environmental is talking about eco-responsibility. Does that innovation use its negative environmental impact to the life cycle of that is possible? In terms of organization, this is where the partnership is talking about.
Thank you very much, Doctor. Please round up. Please round up.
What is the business model and how do we go about that? I would say specifically that, for example, as I'm giving leadership is key. Leadership provided by the Ministry of Health in 2010 and 2020 led to a lot of innovation that has impacted our health. 2019 to 2023, there was leadership gap, and that really affected. And the other thing I would say before, I know I will come back to another opportunity, but as Alan here said, data is the oxygen of innovation. Whether in designing, implementation, evaluation, data is very important, and that's why we should have, like we are running my spirit for HIV, for example, which is very important. We have the data, we are now in perhaps the Ministry of Health, in the matter of statistics, and you see, talking about ownership and accountability. Ownership and accountability is built on which accountability and not an opinion or perception. Thank you very much. Let's take our time to watch.
Thank you very much, Dr. Odutole. It's obvious that's an area he's very passionate about. Yeah, and he could go on and on and on, but he did strike some points there. He spoke about the fact that there was a period of time where we're able to use some of this evidence to drive some of our results, like political analysis. And he spoke about how we have pockets in ATM, so that's your AIDS, tuberculosis, and malaria. But despite the donor funding, we still find ourselves in this situation. So ladies and gentlemen, right now, this is the point where we're gonna really want to hear from you. We want to take this conversation from the panel here right down to you over there in terms of if you have any questions, if you have any answers,
or better still, if you have any contributions that you want to really sprinkle the conversation, the rich conversation we've had here today. And while we're doing that, for our panelists, if you can, begin to wrap up your closing remarks in the next 30 to 60 seconds and think about what will be the future state of health look like in the next 5 years? If you had a wish list, but you didn't have all the resources in the world, with the resources that we have right now, how can we buy more health for us in a more efficient and effective way in the next 5 years, within your domain? So at this point in time, I'd like to really open up the conversation. I see Dr. Bola there. Is there anybody else that has some contributions? I see a hand at the back there. Thank you very much, sir. Do we have a microphone that can go around to them? Thank you, Andrew. And then please, if you can introduce yourself, even though some people don't need any introductions, and then tell us the panelists you're directing the question to, or if it's a contribution. Yep.
So thank you very much, and thanks to Professor Fatusi for setting the tone, and to all the panel speakers. So it's actually mainly to both Prof. Fatusi and Dr. Dutolu, and we're kind of like curious. So we do know that you've said 6%, not up to 10% of what we have, and also to Dr. Ilori, not up to 10% of what the donors bring in actually contributes to the total health budget. So the question is, and based on what I've known from experience, being in the ministry before, that 90%, the question we should be asking ourselves will be, what is that 90% going into? And if you do an analysis of that 90%, you'll find that the bulk of that money, first of all, goes into salaries. The question is, if we're going to change and reimagine health systems, we need to be thinking that if we're paying salaries, are we paying salaries to the right people? Because at the end of the day, we're paying salaries, but people are jackpying. And people in the communities at the lower levels are not getting the effect. The other bulk of our money goes on recurrent costs. How recurrent are those recurrent in terms of efficiencies and also effectiveness? Then when we look at the capital expenses that we invest in as a country, for me it becomes mind-boggling. If we look at the state of our teaching hospitals, if we look at the state of some of the things that we talk about, we find that they are not commensurate with the bulk of the funds that have gone into this. And until we begin to query the status quo, we would not be able to really fit and take this as an opportunity to really grow and get to where we need to be as a country. So I'm asking the three of you, how do we think differently at this point? Because we do need to, otherwise it's going to be business as usual, but very expensive business as usual, because as Dr. Dutolu has said, the funding partners are investing strategically and innovatively and making a difference. The 90% that we are investing, what are we using it on?
Okay, great point from Dr. Bola in terms of efficiency and effectiveness. Dr. Dutolu will still take 2 more questions. All right, so I have one here. Can we get the mic over to her? Okay, Andrew, go for it. No, it's fine, it's fine.
Good morning, everyone. Hope the court observed. First of all, my name is Andrew Chetowa. I work with Center for Clinical Care and Clinical Research. And first, apologies on behalf of my CEO, who was unavailably absent. But there is a song by Bob Marley, which talks about emancipating.
I thought he was going to say Timaya. All right, thanks.
Yeah. Dr. Bola has completed the song.
Favorite song.
It's important. I don't know if I missed it, but nobody talked about the mind shift.
Yeah.
We have not still shifted our minds from donor support. And the first time I got in contact with this was when you talked about in February, and at that time, when the big stick came, there was one of the partners that the staff tried to commit suicide just because of donor cut. And it makes you think critically, why will this young man, there might be other issues, think that his life has ended because donors are no longer going to pay him? So we need to start having that shift. And without that movement, we will remain just doing putting dressing and the rest. We need to make that mental shift. Thank you.
So that's a great point about not going around in circles and ensuring there's a mindset shift. I think there was a question at the back. Just before we counted, there was a man all the way at the back that in glasses, in the red tie. I do like that red tie, by the way.
Thank you very much for admiring the tie. Yeah, so what I want to say, I'm directing this, it's a contribution, but also I'm directing it also to Professor Fatusi. Prof, you remember many years ago when we left the Hadassah, the Hebrew University, you always have this lecture about
Okay, another reunion here.
The social determinant of health. So what I want to say also to moderator, health system solutions are found in other sectors. Okay? Not only in hospitals. You can agree with me that waste disposal is a major contributor, in health. What I'm saying that a lot of things that affect this health are not really in the health. So, what is the Ministry of Environment here? Look at what WASH program is doing. Where is the Ministry of Agriculture for food infrastructure, stomach infrastructure? A healthy man is a wealthy man or something like that. Look at what we are doing in climate change and what is happening. And then they are not here in this room. What I'm trying to say here is that, and if I go to director, NACA, I want to let you also know that there was a time we had what they call the workplace policy. Even agriculture has a policy on HIV. That's a multi-sectoral approach during our late brother, Professor Shotumei. So is it not possible that we begin to work together with other sectors? Prof, I want to hear all you have said. Where is the role of the health, the agric ministry, the environment, and other ministries to be able to talk about the social determinants? I'm sure that where you live actually affects your health. Some person living in Mararaba here may not be as healthy as people living in Asokoro, just because of social amenities they're exposed to. So that's my contribution. It's about where's the role of other complementary ministries in terms of the social determinant of health. It will help us. And I want to tell you, moderator, money is not the problem of Nigeria health sector. It's actually, there are already a waste in the system. I think when we do a lot of things, it's going to free a lot of money in the system. I've been in the system. I'm still a staff of Federal Ministry of Health. I work with United Nations Population Fund, Samson Ezekai, and I lead the health systems. So I talk from the ministry and also from the donor partner. So thank you so much. I hope you help me move this movement forward. Thank you.
All right, thank you very much for that. He spoke about the fact that we need to see how we cut out waste and ensure we have design thinking across our systems. And if Prof has anything he would like to add to that. I think we have enough time for just one more or maybe two from the high table and then the lady there. Thank you. Hi. Yeah. This lady there, and then we'll just take in the front, and we should call it a wrap.
Good morning, ladies and gentlemen. My name is Dr. Aisha Abubakar Sadiq. I'm the Permanent Secretary, Ministry of Health, Kaduna State, and Nigeria's Country Coordinator for GFMRI Switzerland. My comment and question are to the distinguished lady at the end in blue, a color I like. Now, it's about research. You talked a lot about identifying gaps during the COVID response, vis-a-vis Nigerian-based research and gaps in data management that the first speaker spoke about, and other countries in the world. I think a main problem we have, yes, we do generate the data, but we have a problem with harmonization and creating a distinctive and logical inventory. Let me give you an example. In Kaduna State, you have a lot of people coming to request ethical clearance at postgraduate level for undergraduate research within the country and outside the country. I mean, it's an infinite number. But if you ask today, how many research works have been done on primary healthcare settings, for example, or on the HIV, nobody can give you that. There is a highly competent Bureau of Statistics which conducts its own survey, some of them related to health, but there is no harmonized platform. I've repeatedly highlighted this, and I think we as a country, while trying to find a way forward, need to get a harmonized platform across the countries. I should be able to put in a search term and say, for example, zero-dose kits, research on zero-dose kits, and I should see everything that has been done.
Exactly.
I should be able to stratify it by zones. I should be able to see where baseline research questions have been answered, and I should know where I can generate my own research proposal. Now, not only do you get answers to country-level questions, you get a greater opportunity to access more funding that is not from China. I mean, there are funding sources that are willing to strengthen your domestic capacity. Is that not so? And build the skill of your researchers and your healthcare workers, strengthen interdisciplinary collaboration. These grants exist in different categories of different organizations, but we can't even access them because we don't have any evidence to show that we have done this. And what you can do, you compare it. Western countries have sample populations. I have done my second doctorate there. And you see somebody with a study size, sample size of 50. I mean, in your local government area, you can have 250 in one go, and it can be done. But you do not have evidence or documentation or linkages. Nobody can find it. I am not an alumni of University of Ibadan, but it's one of the only institutions that has paid a subscription to most of the global journals, where you can get, as a researcher, a subsidized publication fee. And it's Dairo and Co that have done that. Now, it gives them visibility. Other parts of the country need to do better. I think in the spirit of ownership, we need to do better, and we also enhance the capacity of younger researchers and healthcare workers to have greater visibility and be able to contribute on a global platform. And they get to be in the room. Thank you.
Thank you very much for that. So, Prof, that was a great question on having interconnected systems across the strata. And maybe Kunle can chip in on that in how we can drop some intelligence on those systems.
Thank you, Mr. Chairman and Moderator. I'll try and be brief, although that is going to be a temptation I'll fight against. Because when you talk about health, you don't even know where to start from. It's such a complex, but everything matters. Social infrastructure, educational system, politics, corruption, etc. So where's the silver bullet? Where is the silver bullet? For past 40 years, we've been talking about this. I remember 35 years ago in a seminar of this nature, we went through the same repetition. And sat there another 20 years, the younger guys will come 20 years from now. They may just keep on saying the same thing. There are two issues in Nigeria that we always forget. I'm always amused when people keep on blaming the federal government. Well, I'm not a federal government apologist, I assure you. But we don't seem to understand that the government of this country is based on 3 tiers. And the federal, the local, the state government takes a good chunk of the revenue of your country. And they do absolutely nothing. And nobody bothers. I mean, that's an exaggeration. Some states do well. But I'm speaking in general terms. Nobody talks. It's not like I told my neighbor here, it's not Tinubu they're going to prevent a maternal mortality in my village, even if you give my village $1 million. So the issue here would be, over the last 20 years, we have gyrated to the teaching hospitals. For example, UBTH had about 25 years ago 300 beds. Now it has 900 beds.
Thank you.
Many of the federal teaching hospitals have exploded. More federal medical centers are being developed all over the place. Concomitantly, most of the structures that existed in the states have collapsed over the last 20 years. In Edo State, the local government, the state hospitals were functioning. Today they barely function, and it's not unique to Edo State. We are so stuck on blaming the federal government for everything. One, until we recognize that you must do something about the bizarre incompetence and corruption that is pathological at the state level, we're not going to move anywhere in this country.
Thank you, Prof.
There's a limit the federal government can do. Just a limit. They can't do more than that. That's number one. Innovation. I'm always amused. I remember years ago when they said they were going to be, what do you call it, banking was not going to be cashless in Lagos State, I laughed, and I laughed. 6 months later, I was no longer laughing. Today, the lady who sells you bole on the corridor on the high street in the village has a POS.
And it is a money point.
Everybody now has a GSM. Technology has advanced when it comes to money. Why are we not using it to advance our health systems? The gentleman talking about AI, I thank you very much. I honestly think that innovation we must get away from the standard thinking. We must think out of the box.
Absolutely.
And look at what is positive in us. This, everybody has it. Down to the grandmother in the village. This is it. This GSM is going to be the key to developing our health system. Above all, please beg your state governments to do their jobs. Thank you very much.
Thank you very much, Prof. I can see that was something that really resonated very deeply with him, and he did make some profound points, that maybe we need to be a bit more disruptive in our thinking. Maybe the innovations we're putting on the table are not enough to really transform the landscape. So we're going to quickly get some responses, if Professor Alesh can just quickly give some responses, and the others, and then we can just call it a wrap. Thank you very much.
Thank you. It will be brief. I really appreciate the comment by my sister from Kaduna State about data and everything. I think you bring a lot of complexities in a nation like Nigeria. Nigeria is 37 countries, no doubt about it. So, but there is, with the new technology, ways that you can use whatever platform you have, as long as they speak to each other. But understand that as a researcher, you're filling in your data in what is available. So, for instance, one of our funding by CDC was to support NCDC to make sure that all data coming from subnationals go into their systems of SORMAs. And it's just to get all those data systems to talk to each other. So, although it's really complex, but somebody needs to own that data and make sure that there are platforms that allow people to put in their data, so that you're sitting at the state level or at the national level and you're looking at the data and it makes sense to you or not, so that you can query it and all of that. So again, it's real partnership, but whoever wants to own that data as a custodian must set in place templates that just allows you to go online, fill in the data, everything that you're doing, and so you're able to see it.
Would you like to close as well? 30 seconds.
Oh, he wants me to close as well. Okay. All I want to say is I really do want to emphasize on the youth, because the youth, we really need them for tomorrow. They understand AI like nothing, like they grew up and conflict everything. But how much has our educational system taken that into consideration?
Yeah.
So let's go back. Again, I like going back to the basics. Let's look at all of our curriculum. Primary, secondary,
Absolutely.
tertiary, whatever, universities. Are they aware of the importance of importance of data, importance of GPT, chat GPT, AI, whatever, machine learning? You've got to have that information that is so dependable, that data that is so dependable that you put in. So I would love a situation where we go back to our curriculum, we emphasize implementation science or research or anything in what we do, the importance of getting good data, the importance of asking appropriate questions, so that we're not having doctors and everybody coming out. I like the fact that in primary school you have to do math, but you don't have to do biostatistics in university. What's up with that?
All right, a great point from her about decentralizing digital literacy. Any points from our other panelists there?
All right, thank you very much. I think I just want to address one of the questions about not having some agencies or ministries or government ministries in the conference room. I believe that we need to start looking at inter-ministerial collaborations from every sector, all states need to look inwards and ensure that whatever you're doing, probably you should be able to align it with other ministries or other agencies of the state. So for me, I would say for a long-term impact, Nigeria must move from interventions to a systemic or a community-led models. We need to know that the community, we should see them as not just as an end users of any interventions, but we should see them as the co-engineers of public health progress. So finally, I would say the next frontier of health innovation is not digital. It's not digital, it is social. It is part of the communities that people believe lead and sustain the change key to help that we are going to create in the future. Thank you.
Thank you very much for that.
Thank you. And for me,
I think it's a mix.
I would go back to the subject of resources. I think, so if you look at data out there, the digital health, not digital economy, is currently valued about $1.5 billion, digital health for Nigeria. Also, the AI market in Nigeria is valued about $3 to $5 trillion. I'm not talking about AI for health. AI for health is still about $2 to $3 billion. And you can check it out online. Deloitte, BCG, Ken Research Group, they have these numbers out there. The global AI market, now we're talking about zillions in dollars of investment that is attracted. The hyperscalers, the Llama, the OpenAI, all of them are building infrastructures that are into billions of dollars. And I'm going somewhere with this point. The global economy, whether it affects health, climate, all gravitates towards global economic investment, whether they are the real things or not. And let's come back to the need for us to not talk about health systems being reimagined without talking about looking at how to mainstream digital intelligence. And I like the way Prof had captured it. And from Dr. Lillian to Dr. Bola to the NACA DG, they have held their phones several times while we're in this conversation. Whether we like it or not, it has immersed our lives. WhatsApp, they give us for free, but we spend critically minimum about 6 to 8 hours on WhatsApp. Some of us, when we wake up, that's what we look at. And there's no way we can talk about health, delivering health to the people without talking about how to use what is the closest to them, what they spend the most time with and about. So coming back to how can we make sure that health gets to the people. Recently, ordinarily, telemedicine market in Nigeria that erupted in COVID from about 18% to about 40%, it's becoming one of the major frontiers in a number of states. You just go to the hospitals and all you interact with is a screen with doctors from all over the world. And that is the power of digital. That is the way we need to begin to think about our health systems in low restraint settings. We cannot shy or run away from it. And that's why if you look at the global health strategies, and I keep going back to that, because money and resources push the direction of decisions and policies. And that's why we need to look at where's the resource going to. In the more recent times, a couple of days ago, Makoto Foundation, Ford Foundation, Mozilla, and a couple of other people announced a $500 million investment in AI for humanity. It's called Humanity AI. And for you to see that as the world is shifting, the investment is moving in a different direction, and that comes down to how we receive health, how the community would receive health in the future. I just, at this point, I think I realized that there's a need for us to not just make a mind shift, make a knowledge shift, become AI fluent, become digitally literate. And one of the things that we have been doing with organizations is doing AI readiness for organizations, because that's the future of a lot of things that evolves around our lives. A lot of people that are not even literate are able to even generate photos on ChatGPT just because it's available on their phone, and everybody, there's a lot of investment, there's a lot of drive towards it. We can't shy away from some of these things that the world is gravitating to, and it affects everything that we do, including health. At this point, I will stop, but just to convince us, and not to confuse us, that the earlier we become digitally fluent, digitally literate, AI capable as organizations, and ready for the next shift, the better we are positioned for helping people get better health in the future. Thank you.
All right, thank you very much. I know there's a few questions that are thrown at Prof, but Prof is here with us. So, during the tea break, during the lunch break, just grab Prof, and then you can continue those conversations. Can you please kindly give the flowers to our panelists here? I can see Dr. Rutuli there. Do you have something you want to quickly put out there before we wrap it up? 60 seconds. 60 elevator pitch, please. You're muted, sir. Can you try again? Hello? Can you try the mic? Oh, you're still muted. Oh, you know what? I can hear you now. So if you can just quickly wrap up.
Yeah, for few minutes. We had the talk about to answer the last question on allocation of budget. I think we should de-emphasize government at the state level, spending all the ahead budget of the state hospitals. Dr. Ilori was a commissioner in Washington State years back, and I know that most of the budget went to now take state hospital, and you have no money left for population health as it were. What I would say is, can we just say veterinary care to be seeded to the private sector, let them more money and run it more efficiently, and we face primary health care and secondary care, federal, state, local government.
The DG NACA is not in here.
So I would just stop here because of the time.
All right, great. So let's give everybody here a round of applause. Really incredible conversations. If there's anything you need to take away is that we need to have design thinking. Make sure you're scaling up your digital literacy, all right? And let's see how we can decentralize it. And let's be connected. So ladies and gentlemen, in the next 5 years when we're looking back, we're saying that Africa truly stood up and Africa truly built. Thank you very much.
Ladies and gentlemen, a warm round of applause to our panelists. A warm round of applause to our panelists. Thank you so much for that brilliant session. Before we go on our tea break, we'd like to take a group photograph. Ladies and gentlemen, a warm round of applause for Dr. Kunle Kakanfo. At some point, I'll tell you why, at some point I was wondering, is this human speaking or artificial intelligence? Thank you so much, sir. Thank you so much. So I'd like to take a group photograph, and I'd like to invite Dr. Bola, Professor Fatsisi, and Dr. Temitope on stage, Dr. Ilori on stage, and all CEOs here.
Thank you very much.
Please kindly join us on stage for the group photograph with the panelists. So I think some group should be here, and then the other group down the stage, and then. Okay, all right. Sorry, apologies. We'll take the panelists first, and then every other person join. Yes, panelists first. Dr. Odutsulu, please, can you kindly put Dr. Odutsulu on the background? Okay. I guess he's dropped off. Okay, all right, all CEOs and then everybody, please. Everybody, Honorable Commissioner Ma. Some persons are still coming. Just a moment. Just a moment. All right, thank you so much, ladies and gentlemen. Once again, a warm round of applause. Sir? Okay, also to join us on stage are the State Ministries of Health, Ministry of Health in Kogi, Kaduna State Ministry of Health. Please kindly join us on stage. Kaduna State Ministry of Health, Lagos State Ministry of Health, Kogi State Ministry of Health. All right, thank you so much, ladies and gentlemen. A warm round of applause for yourselves. A warm round of applause for the panelists. Thank you, Dr. Chris, for that awesome session. Thank you, Dr. Anima Shao. Thank you so much. Thank you, thank you, thank you, thank you, thank you, thank you. All right, I'll just inform that the press will be approaching some of us to interview. Please, while we go on tea break, you'll be having interview sessions with the press. Okay, thank you. Thank you. All right, ladies and gentlemen, while the pictures are still going on, we would like to break right now for tea, and we'll be converging around 1:30. Okay, please, all our sponsors, please make way to the photo stand and take pictures with the CEO of CIHP. All our sponsors, NACA, NASCAP, please come forward for pictures. All our sponsors in the building. Thank you so much. 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 At this point, please feel free to break for tea, and we reconvene at 1:30 p.m. Sorry, we're breaking for 15 minutes. 15 minutes, we'll reconvene at 1:15 p.m. So please feel free to break for tea. Thank you so much. A warm round of applause to yourself. Yes, so the tea is outside the auditorium at the garden. Please, let's use this opportunity to also network. Let's use the opportunity to meet some persons. Please use this opportunity to also make friends, network, expand your circle. We reconvene at 1:15 p.m., please. Thank you very much.
This sustainability at a time of global transition. Thank you for being part of this historic moment. The Center for Integrated Health Program welcomes you to the 5th Scientific Roundtable Series 2025. This year, we are reimagining health systems, innovation, ownership, quality, and sustainability at a time of global transition. Thank you for being part of this historic moment. The Center for Integrated Health Program welcomes you to the 5th Scientific Roundtable Series 2025. This year, we are reimagining health systems, innovation, ownership, quality, and sustainability at a time of global transition. Thank you for being part of this historic moment. The Center for Integrated Health Program welcomes you to the 5th.
Nǹkan tẹ́mi wá síta wá fún mi pé kíní tí nǹkan tí mo wá fún lẹ́nu ọ̀tọ̀ nǹkan tẹ́mi wá pé kọ́kọ́ gba kíní kí n máa lọ bẹ̀ táwọn nǹkan tó ń ṣò fún wa lẹ́nu ó jẹ́ kí n mọ̀ pé mo ṣì ní ìrètí ó dẹ̀ jẹ́ kí n mọ̀ pé ọkàn mi ó jẹ́ kọ́kàn mi balẹ̀ pé mo ṣì máa jẹun ọmọ gbogbo adẹ̀lá máa jẹun ọmọ torí ìdí tí mo ṣe sọ bẹ́ẹ̀ ti tèmi yé most especially our single mother. Ohun tá à ń go through most of the time tá a wà yìí kò kéré àmọ́ mo dúpẹ́ lọ́wọ́ Ọlọ́run fún tí mo rí lẹ́yìn ó jẹ́ kọ́kàn mi balẹ̀ lọ́pọ̀lọpọ̀ pé mo sì máa jẹun ọmọ torí bí mi èmi tí mi ìjà mọ́ nǹkankan tọ́mọ mi bá délé tó bá ń fi fóònù ẹ̀ fi hàn mí àwọn nǹkan tó ṣe àwọn nǹkan tó ṣe gbogbo ẹ̀ mo ní fún mi tó bá dẹ̀ gbé kínú ẹ̀ fún ẹ̀ kí ní ìfún ẹ láti tà pé kò ṣe ṣé o lè ṣe bó ṣe fi hàn mí ó ní fún mi I will do more than that mo ní mo ní o sì lè ṣe gbogbo nǹkan báyìí gbogbo tó jẹ ṣe agbára mi pé kí n tún fi ra láptọ̀pù lápẹ́ wàá tún.
Welcome back, distinguished ladies and gentlemen. Please feel free to reach out to your colleagues and inform them we're about to start the second sessions. Please look around you. If you can't find the person who sat next to you in the first session, kindly reach out to them and start asking them to come back to the hall. We're about to start. But before we start the second session, let's just have a light energizer. We've had tea break. Now let's test our memory a bit. Ushers. Hello? I'd like for you to please take this question to that table over there where you have Dr. Prince. Dr. Prince, something is coming to you. All right. Can we please have the second mic? Dr. Prince, don't worry. Relax. I'm sure you got this. You got this. Dr. Prince, please can you kindly make yourself... No, don't do that. You broke the rules. Okay, I didn't give the rules. So the rule is take that bowl and then make yourself proceed to the front. A round of applause for Dr. Prince as he makes his way to the stage. Okay, so you're going to read what's in that paper to the audience, and then you answer the question. So please, read out.
So the question reads, who is Professor Mohammed Ali Pati?
Dr. Prince is on you. Who is Professor Mohammed Ali Pati? You can call a friend, you can phone a friend. I can see people bringing out their phones to check AI, to check ChatGPT. And by the way, there's a prize for whoever wins this session. Dr. Prince, you have 1 minute to answer the question, and your time starts now.
So is the person in this room?
Sorry? No, wait. There is no random answer. Allow Dr. Prince to take his time. Dr. Prince.
I do not have an idea, so I'm going to phone a friend.
Yes, phone a friend. No. There's no wrong. It's an energizer. So I think there's somebody who wants to help out. You can phone a friend. His name is Alit. Amit. Yes.
He's the Minister of Health.
He's the Minister of Health. Please, a round of applause for Amit.
Thank you for saving the day, Amit.
Amit, we'd like for you to please come to the stage so we can give you your prize. A round of applause for Amit. A round of applause for Amit. Please keep clapping for Amit as he comes to the stage. Thank you. So you see, over tea break, I had a conversation with Amit, and he said that he doesn't like to stand in front of people. That's exactly what he told me. And then here he is standing in front of people. Ladies and gentlemen, a round of applause for Amit. So thank you. On behalf of CIHP, I give you my honorable handshake as the gift. Please, you may make yourself to the scene. All right. A round of applause for Amit. All right. We'll take one more and then we'll go into the session. Usher, take the bowl to... Take the bowl to the table where you have my honorable director, Dr. Collins. Dr. Collins. I'm sure you'll get it. Dr. Collins, don't open the question. You bring it here, and then I'll look at the question. If it's a question you will not get, I will pass. But if it's a question you get it, you get, then I'll ask the question, because whatever I do now can be used against me in the court of law.
I guess you know how to read minds now.
All right, Dr. Collins. So, can you please open the question and should we do this? Dr. Collins, you can phone a friend or skip. Okay, you have three options. Ask, phone a friend, skip.
Skip.
Thank you very much. A round of applause for Dr. Collins. Skip. That was wise. That was wise. Thank you very much. Okay, I'm going to hand this the question to another table. Go to where you have. Yes, this final question. Okay, let's take this table. We haven't tried anybody here. This table. Online viewers, can you say hi? Online. Oh, online. Someone said online we use ChatGPT. So let's restrict here. Okay, please pick a paper. Yes, gentleman over there. Thank you, sir. Yes, sir. Thank you. Please make your way to the front, and then we'll round up this session and go to the next on our agenda. Please, a round of applause for him as he comes. By the way, you look good. You look amazing. Thank you, sir. What's your name?
Umahi.
Umahi. All right. Do you want to skip? Do you want to answer? Or phone a friend?
Okay, I'll phone a friend.
Okay. Phone the friend.
I should call the friend?
Who's your friend? Is your friend here?
Yes.
Who's your friend?
Tosin.
Tosin. Tosin, are you here? Is it Dr. Tosin? Yes. Dr. Tosin, please put your hands together for Dr. Tosin. Dr. Tosin, you can check ChatGPT, but the question is, what was the theme for SRT4? The theme for SRT4. Dr. Tosin, you were the one that gave us the idea for this question. The theme for SRT4. Oh, Abubakar has his hands online. Abubakar, please, can you unmute? Please unmute and give us the theme for SRT4. Abubakar, are you there? Okay, are you there? Oh, he can't hear me. Can you unmute? Okay, I think he's on hold on. So SRT4 was the missing link, reducing vulnerabilities of adolescents and young persons through sustainable interventions. A round of applause for me. Ma, with your permission, one final question, because I personally love that question. And they must answer. And I'd like to ask this table. Yeah, Dr. Federico, I don't know if, yes. Okay, you got this. You got this. You phone your friends. All right, so open the question. Open the paper. Okay. Do you want to skip?
I will be justified, I hope. But who is the current minister of the Federal Capital Territory?
Who is the current minister of the...
I don't really know.
His name is... Everybody is very popular. A round of applause. You got it. Ricky, a round of applause for Federico. Thank you so much. Thank you so much. All right then.
So we'll quickly be proceeding to the next item on the agenda. And while Dr. Federico is on the spot, he'll be joining us on stage to introduce the Reach Out Project. But before he comes on stage, we'll quickly play a montage of the Reach Out Project.
Where vaccines have saved millions of lives, far too many children remain unreached. The zero-dose children. The zero-dose children. How can we secure their futures? In a world where vaccines have saved millions of lives, far too many children remain unreached. The zero-dose children. The Reach Out Project was born out of a bold vision to find these children, understand their barriers, and design innovative, equitable, and cost-effective ways to deliver life-saving vaccines to them. NCIHP is pleased to announce that we are part of a global multi-sectoral consortium of 8 partners, which is implementing the Reach Out project in Nigeria, Rwanda, and Kenya, and funded by the European Union under the Global Health EDCTP3 joint undertaking, and led by Università Bocconi, Italy. And meet our partners. Namref Health Africa is implementing in Kenya, CIHP in Nigeria, and CIICN is implementing in Rwanda. Through CIHP's contribution, Reach Out is not only reaching more children, but also redefining what it means to reach out.
Thank you. Thank you. So Dr. Carlo Federici is a lecturer and researcher in health economics and health technology assessment at the Center for Health and Social Care Management at Bocconi University. His global health work includes economic evaluations of digital health interventions for vaccination in sub-Saharan Africa and Latin America, and assessment of maternal and neonatal care programs and rapid diagnostic tests for infectious diseases. Since 2025, he has led the EDCTP3 Reach Out project, promoting equitable, cost-effective strategies to reach zero-dose children. At Bocconi, Carlo teaches decision modeling and health technology assessment. He has contributed to European projects such as COMED and Sagittarius, and published widely in international journals including Value in Health, Health Economics, and JMIR. Dr. Carlo Federici is the Reach Out Central Principal Investigator. Ladies and gentlemen, let's welcome Dr. Carlo.
So, Nakawama, Ekaro, and Otutsu Soma. Oma, sorry. So, it's nice to be on stage, like, talking about something I know a bit better than the previous question, for which I feel a bit embarrassed. So, good morning, everyone. I'm really honored to be here to talk about the Reach Out project. And it's, I must say, like, we are all very impressed by how much inspiring were all the talks that preceded this presentation, and we are very happy and honored to be here. Can you project the slides? Yes. So, next, please. Talking briefly about the Reach Out project. The Reach Out project, as the nice presentation that was shown before, is a EU-funded EDCTP3 project and it's about developing improved strategies to identify and reach zero-dose children in 3 SSA countries, Kenya, Nigeria, and Rwanda. And of course, in Nigeria, the coordinating partner is CIHP, and in Kenya, it's AMREF, Health Africa, and CIHC is the coordinating leader in Rwanda. And the consortium is made of other 5 partners, including Bocconi and other partners in Europe. So the project is structured across 3 main strategic objectives and 1 additional strategic objective. And the first one is very much to generate data and evidence on zero-dose children. And this objective today resonates a lot with the words that have been said about the need to generate new data for doing research, reliable research, and produce robust results. And then a second objective is about designing and co-designing together with the ones that will be using the interventions, interventions that are cost-effective and will improve the capacity to identify and reach zero-dose children. And the third objective is linked to the previous one, and it's about generating evidence to understand whether these co-design interventions are effectively capable of reaching zero-dose children. And there are some guiding principles that are the foundations of Reach Out, and one is the use of data-driven approach, so developing interventions and using data and generating the data and evidence that will support the scalability and transferability of these interventions. We also aim to have an integrated knowledge translation approach. That means that the research doesn't need to be done only by researchers, but needs the continuous involvement of people that we will use the evidence generated from the beginning. So starting from the design stage of the project, so the proposal stage, up to the end when we will deliver our results. And we are also aiming to have an holistic approach addressing both demand side and supply side barriers that prevent households to vaccinate their children. So about some specific objectives of the Reach Out project, we aim to generate new evidence about, as I said, the supply and demand side barriers to immunization. We are to produce freely available geospatial data on zero-dose children, including the novel zero-dose vulnerability index. And this again resonates a lot with the words that have been mentioned during the panel today, and also that by Professor in the keynote speech. And then we aim to co-create and evaluate these interventions through implementation studies, and also by evaluating the cost effectiveness of these interventions. And we also aim to update microplans for about 200 facilities districts, helping using advanced geospatial statistics to improve the capacity of healthcare workers to create and use microplans. And linked to this, we are also aiming to develop a decision support tool that facilitates routine immunization efforts by healthcare workers at facility level. And last but not least, the aim is once we have piloted the interventions in the 3 countries, we aim to assess how much scalable these interventions are in the countries, and also how much transferable these interventions are across other countries in Sub-Saharan Africa. So about the specific activities that we are doing, we are trying to collect and harmonize data on routine immunization and other data that are useful to identify and reach zero-dose children. And this again, a lot of buzzwords resonates with what has been said today. We also aim to collect primary data through a survey to households to understand what are the demand-side immunization, the demand-side barriers to immunization of zero-dose children. We also aim to do a political economy analysis, which I will talk about a bit more later. We aim to do qualitative interviews and focus group discussions with healthcare workers to understand from more the supply side what are the challenges of immunization. And we also aim to enrich geospatial to produce enriched geospatial models and more precise estimates of zero-dose coverage, as long as other equity-relevant data that can be used to prioritize intervention in the countries. So these are fundamentally the activities, the main activities that we are aiming to cover for the first strategic objective, which is about generating new data and evidence. And then in the second strategic objective, we are aiming to co-design the interventions with the persons at a different level in the country, so from national to community levels. And this is a massive effort, but we really believe, and in accordance also in agreement also with what is being discussed today, that you cannot design an intervention without involving the people that will actually be the main actors of those interventions. And the same for the decisions support tool that I mentioned earlier. The aim is to have a very bottom-up type of approach to design the tool, in order that the tool will be useful for the person that we will use it. And also we aim, as I mentioned, to develop this zero-dose vulnerability index, which is an index that will somehow support the prioritization interventions that include or in the population that are more at risk of being zero-dose children. And the subsequent activity will be to test these interventions through a cluster randomized study in each country, and then, as mentioned, we are aiming to have clear stakeholder, extensive stakeholder consultations in order to assess the scalability and transferability of the interventions. So about the first activities that we have done in these first 10 months of project, we developed, led by AMREF, Health Africa, and Seeking, a portfolio of immunization best practices to understand what is currently being done in the 3 implementing countries and in the rest of Sub-Saharan Africa in terms of efforts to reach zero-dose children. And this study led to the identification of 41 interventions that were specifically designed to this objective. We are also looking at the data, and sorry, there are no, okay, can you go, I think we are stuck. Can you go to the next slide? Yeah, this one. We are also looking at data, as I said, to create geospatial estimates of zero-dose prevalence. And the maps that you see here are the maps that have been created for identifying the target areas for the interventions in Nigeria. And as you can see, there are some differences in the estimates depending on which source of data you use. If you look at the first map and the third map, these are coverage estimate of DTP1 using the mix survey households, the survey, and the DHIS2 data. And you can see that there are big variations. And again, this resonates a lot with the discussions that have been done on the quality of the data. We're also looking at other types of data. Next, please. Yeah. Like fatalities and number of interventions, to provide some additional information layers to start the discussion about where the interventions in Nigeria should be targeted. Next, please. So, and the result of this exercise is a map that basically generates priority scores in terms of zero-dose prevalence in Nigeria across the different states and LGAs. Next, please. Yeah. About the supply-side barriers to immunization, we are aiming to collect qualitative data to understand what are the main bottlenecks in the supply side of immunization, of the delivery strategies for immunization. So here we are planning to do extensive focus group, key informative interviews, in-depth interviews to understand what are the real problems, what really hamper the identification and capacity to reach zero-dose children in the country. Next, please. And attached to this, there is also an effort to do a political economy analysis, and this is really much about trying to understand who are the actors, who are the main stakeholders in the country that are involved in the efforts to reach the resource children, but also what is the context, what is the framing. So how is the influence of how immunization is framed on the efforts to reduce the resource children, and also what are the structures and incentives. So what makes people act as they do. And again, I think this is another theme that was mentioned during the keynote speech today about the importance of understanding why institutions do not support, endorse the interventions that are being doing to improve public health. And yes, so this is again about the methods for qualitative supply side and the political economy analysis. I already mentioned that we are doing in-depth interviews, focus group discussion, and key informative interviews involving different actors like subnational EPI managers, health facilities in charges, cold chain officers, community health promoters, etc. So I think it's important that to outline again that the main aim of Reach Out is, or one of the main foundative principles of Reach Out is that we want to do this with the involvement of the largest base of stakeholders and people that will be benefit from whatever will be the outputs of the research. And for the demand-side survey, as we are trying to assess the behavior and social drivers of demand for childhood immunizations. And next, please. And we are using a consolidated framework, behavioral frameworks, the BSD, where we are assessing different dimensions that can impact behavior of households with under 5 children, like, for example, thinking and feeling, what are the social processes that underlie their behavior, what is their motivation to get vaccinated, what are the practical issues, like how accessible are the health facilities to get vaccinations, can they afford it, what is the quality of the service, etc. Next, please. And we are also trying to introduce another element in this survey by doing another exercise that is called best word scaling, where basically we elicit the preferences of households about what are to them the preferred interventions that could support the immunization of their children. And in this case, basically, caregivers are asked to literally state which among a set of possible interventions are the one they would prefer the most or the least. And last but not least, as mentioned at the beginning of the presentation, we are also aiming to do a decision support tool. And again, this is again something that was touched upon earlier in the panel sessions about the use of digital health interventions, like to improve health outcomes. And here the aim for the Reach Out digital support tool, the aim is very much to develop a tool that supports healthcare workers at the facility level with routine immunization activities, and also look at the different, so supporting them in different aspects, like, for example, budgeting, planning, and identifying zero-dose population, etc. So this tool will be populated basically by all the inputs generated within the project, and will be used for the monitoring and evaluation of the interventions during the implementation studies, and hopefully will also inform the scale-up plans and transferability models. So this is in a nutshell what the Reach Out project is. I think well, we are just at the beginning of this journey, and but we are really hoping that we will be able to produce something which is useful and relevant for Nigeria and the other 2 implementing countries and the rest of society in Africa. Thank you.
Thank you very much, Dr. Carlo Federici, for that session. So quickly, we will be moving to the next panelist discussion session will be reimagining health systems through the lens of quality, equity, sustainability in a time of global transition. And to take us through that session is pharmacist Tunji Odetola, who will be our moderator for the session. Ladies and gentlemen, a round of applause for pharmacist Tunji. So I'm going to reintroduce him. So I'll be introducing pharmacist Tunji Odelola. He's a global health system strategist and pharmacist with over 20 years of experience. As managing partner at the Access-Centric and Sustainability Foundation, he leads initiatives to enhance access to medicines and health systems resilience. He previously held senior roles with USAID in Nigeria and Uganda, managing large-scale health portfolios and leading national reforms in supply chain and health financing. His work has averted national medicine stockouts, secured significant cost efficiencies, and advanced local manufacturing. Odelola holds an MBA and a Bachelor of Pharmacy and is recognized for his collaborative, evidence-based approach to health systems transformation. You're very welcome, sir.
Ladies and gentlemen, the next panelist is the Senior Nigeria Health Policy and Implementation Lead at Brink Innovation, the Oxygen Collab, Dr. Adewale Akinjeji. A round of applause for Dr. Adewale. Dr. Adewale Oluwaseun Akinjeji is the Senior Nigeria Health Policy and Implementation Lead for Brink Innovation, the Oxygen Collab, a global initiative funded by the UK Foreign Commonwealth and Development Office that strengthens sustainable access to medical oxygen across low and middle income countries. He brings over 15 years of experience in global health, system strengthening, and policy reform across Africa and Southeast Asia. His work focuses on building resilient, equitable health systems through evidence-based policymaking, market integration, and innovative financing. A PhD candidate at the Karolinska Institute, Sweden, his research explores maternal and child health, service utilization, and integration of community and facility-level care in Nigeria. Ladies and gentlemen, a warm round of applause.
Joining our panelists is the Chief Executive Officer for Development Governance, International Consult, DGI, Dr. Jafar Alawode. Dr. Jafar Alawode is a distinguished public health leader and CEO of DGI Consult, with extensive professional experience managing major health system strengthening projects across Nigeria, Liberia, and Uganda. His impactful career includes leadership roles on numerous donor-funded initiatives, such as serving as Chief of Party for USAID and Country Director for Health Policies. As a key architect of universal health coverage innovations, he has also advised Commonwealth health ministers and led significant health policy. Dr. Alawode is a medical doctor and holds a master's in tropical medicine, complemented by executive training from Harvard and fellowships in public health. Ladies and gentlemen, Dr. Jafar Alawode. I will also be introducing to join the panel Dr. Aisha Abubakar Sadiq. We've already heard her voice today. She's the Permanent Secretary for the Ministry of Health, Kaduna State. Thank you so much, ma'am.
All right. The last panelist is one who is really dear to me, because she is the Honorable Commissioner for Health, Rivers State, which happens to also be my state. Yeah, so before you come up, ma, I just want to use the opportunity to thank you. Thank you and your administration for the great work you're doing in Rivers State. Especially, I want to thank you for transforming maternal and child health care with the policies that you've implemented that has expanded access to reproductive health services. You have strengthened the immunization program in Rivers State, and then you've built innovative hubs for healthcare. We want to say thank you. And at CIHP, we love to invest in people, and then we build strong partnerships. And we are more than willing to have a firm handshake with your administration. Once again, thank you very much, Ma. Thank you very much, Ma. Ladies and gentlemen, please make welcome to the podium Dr. Adaize Ore, the Honorable Commissioner for Health, Rivers State. Dr. Adaize Ore is a consultant family physician, public health specialist, and the Honorable Commissioner for Health in Rivers State. She previously served as the Pioneer Country Director of Planning, Research and Statistics for Nigeria's National Blood Service, a fellow of the West African College of Physicians, Kofi Annan Global Health Leadership Program, Aspen Institute, and several royal societies. She is an advocate for respect. She's known as an advocate for respectful, quality health care and universal health coverage. Dr. Ore is a recipient of the 2021 Montegod Global Scholars Award by the World Health Organization of Family Doctors and the American Board of Family Medicine Foundation, and has received multiple international awards for her work on COVID-19 and blood services, and has published extensively on health systems and policy. Ladies and gentlemen, once again, the Honorable Commissioner for Health, Rivers State, Dr. Ore. Thank you, ma'am. So we'll be handing over the microphone for the moderator.
Thank you very much. If there was anything called a high-powered panel, this is it. And I think one of the most exciting things about having the people we have on this stage is, I call them their reality checkers. Because we sit, like Prof mentioned, in Abuja, in these boardrooms, and we have these conversations. Then when you get to the state, I remember my first encounter was in Kano State. And the commissioner said to me, you people sit in Abuja, and you come up with these policies, then you now tell us to do it. Has anybody come here to ask us what we want? And I think that's why we're here today. We have heard the problem. I say to people that the challenge in Nigeria is not to know what the problem is, because everybody is a problem identifier. But we don't have a lot of solution providers. And that's the transition we need to make. We know that there's been a lot that has been said, the data that has been shared. So I'm going to start off really, I'm not going to put anybody on the spot, but the people have to talk. And that's why we're here. So I'm going to start with Dr. Adewale. You knew I was going to start with you. Now, everybody has talked about the changing face of development. There are those of us who are in this room today that are, I don't like to call myself a victim, I'm not a victim. But we have gone through this transition, and we have seen what we were able to do when we had funding. I remember being in meetings where they would tell you your bond rate is too low. Has anybody here been in those kind of meetings? You people are not spending. Now we're looking for what to spend. So, when it comes to the global transition that is happening now, what does this mean for the African health sector? And how can we as Nigerians position ourselves as the leader? Because whether we like it or not, the rest of Africa is looking at us. And as Nigeria goes, so goes the rest of the continent. So, do you want to take us off on that?
Sure. Yes. Well, thank you very much.
I mean, just to start off, I think a lot has been said about this already. I think Prof's seminal presentation has set all of us straight. And as every speaker has come after me, before me, we've continued to make reference to Prof's presentation. And I think that it speaks to the truth that was in the presentation. But also, I mean, I think what I would take this, I would respond to this from a very personal perspective. Up until very recently, I was based in Bangkok, working with the United Nations, supporting a number of countries across Southeast Asia. And when the funding cut was announced, we had to go full gear, supporting countries to make strong investment cases to donors and to countries to continue the investments. And being the African, being the leader in my department, I had to work with a number of countries. But again, I was the only African in most of the room. And it was quite awkward for me to make those presentations or to lead a country like Cambodia to make an investment case. And at the other side, we would hear, Southeast Asia seems to have made a lot of progress. The money has to go to Africa because of the funding gap. The US government has pulled out of Africa. We need to make cost savings and to reinvest in Africa. And that was the discussion, because clearly the exit of the US government created a huge funding gap. And at the global level, it was more of a very reactive approach to looking under the table, pulling out the funds available to support African countries. But I think that is the unique position we find ourselves as African countries. So clearly, there's a huge funding gap. The other discussion at the global level was because of the huge funding gap, there was going to be concomitant gap in services. Clearly, also the follow-up expectation was that we would have a rise or a spike or a rebound in some of or regression in some of the progress that we've made. So the expectation that was that we would see a rebound in mortality rates, in disease burden. But here we are today, and I think, to be truthful with you, I'm particularly impressed with the position of some of the African countries and the initiatives that has been taken. Clearly, there were impacts of the funding gap, but I would say, using Nigeria as an example, we've taken very strong, commendable approach to address the gap. And I know that Prof also highlighted this in his presentation. And one of the key things he said was, while acknowledging it, was the issues around the long-term impacts. And I do agree that if, again, I think the country is taking the right step in the right direction, but it's extremely impossible that the country implements with rigor and fidelity the initiatives that has been implemented for us to be able to yield the long-term goal. But I was going to, again, I'm going to come back to the points that Prof had made in his presentation as a closing. But I just wanted to highlight, and this has been highlighted already by the head of NACA, around the positive moves that Nigeria made. Because again, the conversation is how do we position ourselves as a leader. And I think we've demonstrated some strong leadership as we responded to the removal or the withdrawal of funding from the US by the US government. One area that we saw strong leadership was in the areas of domestic ownership. We saw Nigeria step up to be able to provide some funding, but also strong leadership in terms of coordination and ensuring that, for instance, for the HIV response, funding was made available, but also commodities was made available, but also you could see strong in terms of engagement at national level, and I would say at state level also. I think the other thing that we've seen is the area of sustainable financing. Yes, there was increased domestic funding that was allocated to areas that were going to suffer from the funding gap, but also we continue to see dialogue within the donor community, particularly the donors, the philanthropic organizations that remain, around ensuring that they come under mechanisms around co-financing, blended financing, to be able to ensure that we have a common pot to addressing issues in Nigeria. And I think that's a positive. The other thing I see is around local innovations. Again, I'll speak to this a little as I proceed. But also I think it's important that we laud innovations and moves and initiatives like the PVAC initiative or other initiatives that is driving that is pushing to see areas around, for instance, improving local manufacturing in Nigeria. For those of us that experienced, not those of us, we all experienced C-19 and COVID. We saw how we suffered in terms of accessing reliable drugs and vaccines when it was most needed. So I think these kind of innovations are well welcome. And I think also we see, in the realm of accountability, through the swap coordination, through the engagement at state level, and trying to make sure that states are more accountable. So I think also we also mentioned from sustainable financing, you see that there's a lot of funding that is being directed towards primary healthcare through the Basic Healthcare Provision Fund. There are a lot of moves and initiatives trying to increase the national and state level the insurance schemes. So all these are good and all these are positive. And I would say that if we were going to see this transition into a legacy and posterity, it's still the elements that we've all been speaking about around ensuring that this is implemented and ensuring that key reforms happen. But the last point I would just drive on this is also a possibility of a missed opportunity that Nigeria can easily move to leverage on. And I'll just make some references on some quick statistics. So Nigeria, we could broadly divide our healthcare system into the formal and informal, right? And when we talk about the informal, we're talking about the public facilities, the hospitals, the primary healthcare centers and the likes, and the private clinics. But also we have the informal that is usually excluded by reason of policy and regulatory framework. So we're talking about the PPMVs. We're talking about the traditional vet attendants. We're talking about the roadside chemist. And data clearly shows that 60% of Nigerians seek health care from these people. We have a very high level of poverty in Nigeria. 75% of people live, 50 to 60% live below the poverty line. 75% of these people seek health care from the informal health sector. And I think that right there is a chain that if proper integration is done, if proper reforms around regulation is done, if proper incorporation is done, we can leverage the value chain, because I've heard a lot being spoken about innovation. And I think the integration, leveraging on the existing informal sector to be able to reach those that are underserved is a key area that could benefit from innovations as we continue to engage. Thank you.
Let's give a big round of applause. That was very well said, because there's the encouragement of the fact that there are things that we're already doing that is taking us on that path of transition. However, as we transition, there is that sector that we need to be aware of and take advantage of to improve access. And for those of us who work in the space of access, those different sectors, anyone that is neglected, that people are patronizing, it's to our own peril if we ignore those sectors. Interestingly, when Prof was presenting, he did mention the fact that, everybody would think the challenge is finance, but maybe it's not finance. It's not just finance. But there's a popular saying that the soup that is sweet, waiting kill 'em. In my language, they say that there's some conversations you cannot have without money. Now, what kind of funding or financial strategies can we look at in Nigeria as we transition away from donor funding is what is going to do this? Government has to pay for this. Someone said to me once, if government pays for everything we want government to pay for, government will die. I remember I was in a meeting once where we were asked to present as PEPFAR to the Minister of Finance at that time, amazing woman. I'm sure you know who that is. And we now said to her, Nigeria needs to put more money into HIV. Our annual budget as PEPFAR is $430 million. Nigeria needs to step up. And she let us finish talking. And then she now said, My total budget for health is not $430 million. Tell me where I'm going to find the 430 you want for just HIV. And that's the reality. So, I'm going to turn to you now, because you are the people on the ground, and you are in touch with the reality. What kind of financial strategies can we leverage to fund this healthcare system that we all want? We want it, but it cannot all come from the budget. So how do we do this?
Thank you very much for your question and for coming to me second, despite my being a reserved panelist without a profile. For Kaduna State, during the earlier presentations, you were talking about an allocation of 15%, right? For health. I'm proud to say Kaduna State has 16%. Okay. So on paper, clap. Not accessed, sign. I have it on paper, but I haven't seen it. Now, this is the reality in the country. I think this emphasizes the fact that we cannot depend on government. Yeah. Clearly, government cannot plug the gap that Trump's tantrum has created, so we have to strategize or think out of the box. Now, what strategies do we have in place? Lagos has proven that taxation works. Yep. I mean, the Western world has accepted that taxation does work. It provides you generate revenue you can allocate to priority areas like health. But we have to strategize out of the box, not just income taxes, those debited from your salaries or paid as a citizen, not just taxation from companies. What about taxation on sugar-based drinks? Taxation on alcohol? In France, I was a resident for quite some time. In France, taxation on alcohol is channeled to the health sector. Now, if you know the French, you know they will drink. If you don't know the French, just observe a shop on a Friday and you know they will drink. So you can imagine the money that gets sent to the health sector if every one of us in this room is going to buy a bottle on the weekend, or at least one for the household. I mean, that's an endless supply of money. Why don't we tap into what we know can generate revenue for us? We can tax people for mining. Kaduna has high reserves for natural elements, a lot of natural resources and ores. People mine indiscriminately a lot of parts of the country in the north. That's money we can access. Kaduna is fundamentally a civil service state. Yes, we do have agriculture. The manufacturing industries have generally been grounded. So you cannot depend on the intrinsic revenue. You have to diversify. That will give you money you need. Then you look at health insurance. We have a very good health insurance agency, but every time I speak to the DG, he has a tantrum because the government does not meet up with its own contribution. So you debit from source, from people who are employees, and then the government doesn't meet up. So you get to the hospital at the point of care, and the quality of care which health financing models, effective ones, are supposed to achieve is still not attained. Equity is still not attained because they do not have the full compendium of services or to drugs or rehabilitative access. It is a problem. And then you look at private sector enrollment. There is a state in the East, you know, it's amazing what you forget when you want to remember it. And the DG is my friend. His health insurance agency is now almost run solely by enrollment from the private sector. He went to his governor, he asked for seed money, it was given to him as a bulk sum, and then he went on a mass campaign with commercial motorbike holders, he went to shops, he went to market women, and now you are in a state and you start saying, I'm taking my wife to the hospital, and somebody driving a keke napep will say, do you have health insurance? Why don't you have health insurance? Let me take you to their office. So he has a massive influx, and it's now sustaining itself and has expanded to capacity building for his personnel. It has expanded to an improvement in healthcare. I have to remember this boy's name. Okay, he's not a boy, he's a man. I have to remember his name. Simon. Yes, it's Simon. Yeah. So he's doing amazing. It shows you that health insurance works. And we have to take ownership. A lot of politicians come out and say, I'm giving you free medical care. And the approach in Nigeria is out-of-pocket donation. You put people together and give them money. But I always ask them, how many times can you give somebody money? A health insurance package that covers a family, I believe, is 40-something thousand per annum. So why don't you pay for it? So we need to have a mindset, a change that understands that it's about sustainability when it comes to financing, because it's a recurrent expenditure that you can't possibly meet up with a household income. So why don't you set it up in a system where you can ensure the quality of health? So it's a one-off, you pay a year and the person doesn't come back to you with his 3 wives and maybe 15 children. You know, and that works. Yes, we cannot say Trump is not into us anymore. He might be again, we hope. But donors have a role to play. Earlier I spoke about opportunities through grants. I've had the privilege of working using grants. Research grants, not directly channeled into the health sector, but for academic research. But the outcome of that research will justify greater access to other sources of funds, other institutions, other places where you can have referral for your patients, you can have your healthcare workers being trained to improve their capacity because of the outcome of that seed money from the initial research grant. So why do we not access such innovative methods of getting funding that is not purely about give me money to buy drugs, or give me money to buy test kits, or give me money to fix my hospital? For example, Kaduna State has a 300-bed specialist hospital. The Arabs call it the albatross around our neck, because according to the Islamic Development Bank, they've never had a project that refused to end till they came to build a hospital in Kaduna State, northwestern Nigeria. But fortunately, it has finished. The money for that hospital was actually donated by the Islamic Development Bank, I think almost 70 to 80% of the funding. They donated state-of-the-art equipment, a cancer treatment center, the works, and everything was fixed, priced in internationally. So it didn't matter about the dollar inflation. We still got the equipment that were fixed. But what the state is giving in return is to ensure maintenance, human resource for health, and management. Nobody is coming back to give us more money. I mean, we've done it for you, take responsibility, and then there must be absolute transparency because we want to see who manages it. That brings me back to my last point, because I don't want it to be a lecture, and that's public-private partnership. Somebody spoke about us handing over some things to the private sector. I'm not in agreement, because the private sector has a clear bottom line, and that's what? Profit. I mean, medicine started as an art. Now it's a science, and now it's a what? It became a science, now it's a what? It's a business. It's big money. It's like selling wrapper in Yaba market. You mark it up the way you want to mark it up, and you make your money off. There has to be some sense of accountability. The only systems that have worked to sustain that is when there is public-private partnership and there is a sense of ownership by the government. I have an oxygen plant in Kaduna State and a neonatal unit. The neonatal unit was set up by UNICEF. They built it for us. We gave them a concept note. We said we have a space in a secondary health facility, and they built it. The state is supposed to take responsibility for staff. That is our own part. Now I'm having to write letters to beg for money to maintain the neonatologist in the unit. So they don't have to give you money. They can give you something else, but you have to bring in what you have to sustain the sector. And you have to have partnerships that work. Thank you.
For someone who was drafted in at the last minute, can you please give her a real round of applause? Because you would have thought she was prepped for that. But those options are clearly, they're very clear. They're obvious what can be done. And one of the things we've always loved about public-private sector partnerships is you get to leverage the strength of both. And I love what she said about taxation. Somebody has to pay for these things. I'm going to pivot to you, Dr. Jaffa. You know that because you just spoke about health insurance. So, I'm coming to you. We were at the health financing workshop a couple of weeks back, and we had that presentation from I think it was Abia State. And it's so interesting that one of the states, what the head of the insurance program did was he asked the governor for money to pay premium for all the pensioners. So that way, once you retire, your insurance for health is paid for. And that was part of their benefits. Health insurance works when people see the benefits, and that's the challenge. The people in this room that are paying to HMOs, we get the benefits, because when you pay a premium that you think is high, don't pay that premium and go to the hospital for one surgery. 2 years ago, I had knee surgery, and because I was working in an international organization, the surgery was done in Dubai. The fees for my surgery was $25,000. I was paying a premium of $250 a month. There is no way I would have bankrupted. I would have probably put my house on sale to pay for that surgery. And that's the benefit of health insurance. So, Dr. Jaffa, how can we strengthen accountability and governance structures? Because you raised the valid point. Even for health insurance, the people pay their portion, but then the government doesn't step up. How do we hold government accountable? We were talking about the red letter. Yes, the red letter has gone out, but I'm from Ife Central local government in Osun State. They did not tell me how much is coming to Ife Central. They did not tell me how much is coming to the primary health care in my place, so that I can then pick up the phone and call my people and say, follow up with this man. He has this much money for the primary health care. So, over to you, sir.
Okay, thank you very much. I think before I go to the specific topic of accountability, I think there are a couple of things to familiarize ourselves with when we're talking about financing health and what is changing in our space. So to start with, we're talking about donor transition. Where would the additional money come from? Let's be mindful of the fact that the current macroeconomic reform in Nigeria is generating more revenue for government, federal and the states. There are some states that have their revenue double in recent time.
Yes.
At the national level, the revenue has increased as well. Naira revenue anyway, because when you convert it like we got another revenue entirely. But at the same time, what is the issue? Different states are doing different things. Some decide to spend more money on health because they have received more revenue. Some of them were actually doing things they were not able to do before. Like, for example, recruiting more health workers, like paying the ComHealth, Madam, I was with the Excellency, was telling us all those things they were doing in Kaduna the other time. But at the same time, during the same context, we have health expenditure reducing in other states, despite the fact that the money is going on. Why is this happening? Because we're actually not tracking. And we are not comparing states. States are very, very sensitive to peer comparison. When you put Kaduna, Kano behind Jigawa, it's like Jigawa that was created yesterday, why are you comparing those? That is number one. Number two is that within the context of a donor transition, even your former office, now Department of State, they are saying one of the reasons why they scrap USAID is that less than 40% of money spent on health actually reach the front line, according to the gospel of Trump. Anyway. So that's another thing we have to look at. But when it comes to the issue of accountability, I think we have to pay attention to a couple of things first. We have to look at our institution, healthcare delivery institution facilities. We have to look at ministry departments and agencies. Do they have the necessary managerial capability to deliver on their mandate before we even talk about accountability? Let me give you an example. So at DJI Consult, we did a bit of work for MPACDA and USAID implementing partner on facility and financial management capacity strengthening for health workers, for frontline health workers. I'm not talking about people in the ministry. You discover that a typical in charge in the health facility is somebody that is a nurse, a chief, and all those that has not gone through any managerial training. And suddenly, that fellow is one managing man, money, material, and information. That's a huge gap. Because when we are holding them accountable, we are asking them to deliver what they are not able to deliver. So the starting point is that we have to bridge that managerial gap. And we do it. A lot of capacity around even simple things like planning, governance, managing workers, managing money, managing material, managing health facility itself, so that it does not dilapidate. Even the little resources that you have, how do you manage that resources to manage the facility? And then we saw very, very good results. At both sides, at the level of ministry, department, and agency, we did a lot of assessment amongst primary care board. Simple managerial things like planning, effectively implementing that, having meetings were not happening. And we are talking about high level things. So we have to try as much as possible to fix all those areas. Then now come to the issue of accountability. So accountability, there are three, unpack it as one, transparency. You can never hold anybody accountable for what you don't know about what they do. If you don't know how much I earn, you can't hold me accountable about how I spend this money. The number two is the answerability. Even when you know that they are not doing this and they are doing this, why are you able to do it? And the third one is course correction. But let me speak about an existing plan to strengthen the accountability. So, using the Basic Care Provision Fund as an example. So, for the past couple of years, some of us working in this space, we designed a robust accountability framework, where from the community to facility to the state to the federal, we are able to define what exactly are we looking out for when this money is sent down to the health facility. So in terms of a programmatic area, in terms of service delivery, in terms of how the money is spent. And then when this tool is delivered, when you ask questions at the facility, using technology, everything is aggregated. And in the office of the minister, the commissioner, and everything, you can see, at a just press of a button, what is happening at each of the facilities. And bringing in community to be part of it. Because part of that framework is the community satisfaction. It's not enough for me to say many people will receive this facility. What is their level of satisfaction? And not only that, one of the reasons why we are transferring money to facility is to reduce out-of-pocket expenditure. Is these things, is the out-of-pocket expenditure actually reducing? And at the state level, where they aggregate this as well, they will be able to say this facility is performing, this facility is not performing. Then we ask a question accordingly as much as possible. And again, it's not enough for only government people. It's very important for non-state actors to be there. Because there are instances where we had that the money is finding its way back from facility to some ministry, department, and agencies. So it's very, very important for the non-state actors to be part of this as well. So what the minister says is just one out of several things that is happening at the moment. And by the end of this year, that accountability framework will be rolled out. But what somebody now said, there are different types of accountability. He said, but the most important accountability is personal accountability, where we ask ourselves questions. I have the mandate to do this, I've been paid to do this. Am I actually doing this? Are we getting value for the money? But at the same time, I think we really need to raise the accountability by using a structured mechanism, not a knee-jerk reaction to what is happening. So that at the end of the day, because in as much as, I'll end with this for this round, 50 years ago, one of our leaders said money was not our problem, but how to spend it. 50 years after, money is our problem, and how to spend it is our problem. Because we are very, very inefficient. If you look at a typical state in Nigeria, they spend more than 70% of health budget or human resources for health. And that is a black box. Because a lot of absenteeism, ghost workers, and everything. But at the same time, technology is working. If you go to Gombe, they deploy biometric attendants, exactly, which other states are doing. Guess what? Before then in Gombe State, somebody is on payroll in Gombe and is living in Abuja, collecting the salary. So I think we have to do a number of things, but at the same time, we have to, leadership is very key at all levels. We have to ensure that we hold people accountable for what they're supposed to do. Thank you very much.
Thank you, sir. Thank you very much, sir. I'm going to come to you, Dr. You've done some really good stuff in your state, and we'd like to learn from you about what practical strategies can help us deliver truly equitable health services that ensures every child, woman, adolescents, and the community is reached with quality health services. My colleague did mention that you've done amazing things for women and children, so we want to learn from you on that.
Thank you very much. Can everyone hear me? Thank you very much for that question, and thank you for the vote of confidence in the work we've done in Rivers State. I think it's still a work in progress. And to share some of what we actually co-created and co-designed to achieve, we started from the perspective of being, first of all, people-oriented, being open to community dialogue, community criticism, and community feedback. And then also recognizing that we are a very geographically diverse state. Now, someone was asking me, where exactly is Rivers State? And I said it's at the bottom of the Nigerian flag. When you look at the map of the country, we're at the bottom right before the Atlantic Ocean. And so we have the upland terrain of the state, which is the dry land, and then we have the riverine. And 70% of our population are rural dwelling. And so when the slide came up in your presentation about zero-dose children, I actually sat up to look because we do have zero-dose children in Rivers State. And majority of them are in very hard-to-reach, remote and riverine communities. So early on in the administration of Governor Fubara, in articulating our health sector delivery roadmap, we wanted to focus on certain things. And so we developed a 7-pillar strategy. And the first was financial and geographical access to healthcare. The next was accessibility to essential medicines and commodities. The next was human resources for health. Then there's health security and emergency response. Then domestic resource mobilization and action-oriented partnerships for healthcare. Then, of course, there's been a lot of conversations around data, around health information. And so that was the next pillar. And then the last pillar is something that's been referred to since we all convened here on this platform: leadership and governance for healthcare. So if you look through these pillars, you can see that there was no focus on maternal health, or child health, or adolescent health, or non-communicable diseases, or HIV and AIDS, because our approach was holistic and systematic. If the system works, if the system is comprehensive, if the system is robust, strong, and resilient enough, each of these individual groups, say mothers, pregnant women, newborn, children under 5, the elderly, will be sufficiently captured. And so taking us to financial accessibility, which is basically health insurance. As at May 29, 2023, when Governor Fubara was sworn in as governor, Rivers State was the only state in Nigeria that did not have implemented health insurance. And Dr. Gafar is here to attest to that. We were the only state out of the 36 states and the Federal Capital Territory. We did have a law, but it hadn't been implemented. And so, drawing from a household survey that was done in the state in 2022 with the support of WHO, out-of-pocket expenditure for the households in Rivers State, majority of these households, by the way, were earning less than 40,000 per annum.
Wow.
And out-of-pocket expenditure was upwards of 95%. The national average was 70% at the time. And so it was a no-brainer in communicating, first of all, to a state chief executive that is community-oriented and healthcare inclined, that we needed to implement state health insurance. So that's for the financial accessibility bit. Then for geographical accessibility, I took pains to mention the kind of terrain that we have in the state. So in previous administrations, immediate past administration before Governor Fubara's, there was a lot of investment, as had been mentioned in the room since earlier today, about investing in the state teaching hospital, the tertiary level of care, and the significant infrastructure and capital investment that goes into that. But like I was saying earlier, sometimes that kind of investment, when you neglect the primary healthcare sector, the secondary level, is like giving money something with one hand and taking it back with the other. You're investing significant financing in the specialist level of care. Why? What is the specialist level of care? It is for innovation, it is for development, it's for advanced level research that will translate to improved healthcare delivery. But if you invest those significant sums and the primary healthcare sector is neglected, the secondary level of care is abandoned, everyone from the remote, rural, sometimes riverine communities feels the need to go back to the state capital to access quality healthcare. So the people at the tertiary specialist level of care do not have time to think about innovation, to think about even research questions, and to innovate, because they are treating maladies, ailments that could have been addressed sufficiently at the primary healthcare level. And so from that perspective, which was why we were not emphasizing on advancing primary healthcare or secondary healthcare or even tertiary healthcare, those things happen organically when you look at the healthcare system as a continuum and a holistic unit. And so for us, this is where we now came to the missing middle. By virtue of the 1% basic healthcare provision fund that comes from federal, there has been over the last couple of years a lot of emphasis on primary healthcare delivery. In addition, there's something that we have, which I presented to the National Council on Health in Ekiti 2 years ago, which is statutory allocation of funds from the state to primary healthcare. So there's a running joke in the state, and it's that our primary healthcare delivery system is the 24th local government area of River State. Because as each local government area is receiving their allocation monthly, PHC is receiving its allocation monthly. And so it is not subject to the whims, the caprices, or the moods of the chief executive or the local government chairman, because it is backed by law, and that law has been in effect since even the previous administration under His Excellency, the present Minister of the Federal Capital Territory. That law has been there since then, and it has continued. It is institutional. And so that way you already have a block of fund to build your primary healthcare centers. So for us, identifying these 7 pillars, backing those 7 pillars by commitment of state investment doesn't mean that we're not looking for partnerships. For us, partnerships are a means to grow what we're already starting to sow and to galvanize the achievements that we can from our own state level investment. So what we're also doing currently is building for over 2 decades, there was little or no improvement in our general hospitals and cottage hospitals, which provide the secondary level of care. And so there's ongoing upgrading of those hospitals in communities. We just commissioned the Bori Zonal Hospital in Kana local government area, which is in the heart of Ogoni land. It serves 7 local government areas. And prior to that, people had to move from PHCs in those local government areas all the way to the state capital in Port Harcourt for referral services. So what we saw by the time we were commissioning is that attendance at the community level healthcare services increased by upwards of 60%, from 589,000 in terms of attendance to upwards of 1.1 million people just at the community level. Imagine what that does for quality of care at community level, what that does for capacity building, capacity development for our healthcare workers. And also to add that in the last year, we've employed 2,000 healthcare workers, 1,000 for tertiary and then 1,000 to be distributed across all the local government areas in the state. And there's something of an upward mood in the state right now, because they just started receiving their salaries yesterday. So there's been a buzz of excitement at the community level for the building of human resource and the workforce in our communities. Thank you.
Thank you very much. So, my compere at the back there has told me that I do not have permission to ask any questions. So he's coming up to come and explain himself. Yes. So he says your closing pitch must be 10 seconds and I must time everybody.
One round of applause to the panelists. Thank you so much. Thank you so much. So we'll take a few questions, but this time around we'll start with the online community. So the last session, they asked a few questions, but we couldn't take them. But now, for those of us online, please, if you have questions, kindly drop on the chat box. And then, or you can raise your hands. Yes, please. You can raise your hands and we'll call you up and then we'll take your questions. Do we have any questions online? Any questions online? Please, I'd like for the projector to please come up so we can see. Do you have questions from... Check the chat box, please. Okay, while we're waiting for the online community, can we take one question?
There's one person at the back there.
Okay, all right. We'll take your questions and then we'll come back to the chat box. Let's take this question and then we'll come back to the chat box.
Thank you very much. I just wanted to ask the Honorable Commissioner of River State. You said there was an increase in attendance at Bori General Hospital, almost ×2. How were you able to resolve the manpower issues in that facility? It wasn't clear what you said. It wasn't clear how you were able to improve and increase the manpower capacity in Bori General Hospital. The General Hospital is serving 7 local governments. Thank you.
Thank you very much for that question. This microphone is better than the one I use.
My apologies.
Thank you for that question. What happened was that as the upgrading work was going on for the zonal hospital, the past general hospital, the old general hospital in Bori, was still functioning, but obviously not at the capacity of the zonal hospital. So you have about 25 to 30 beds space in the general hospital compared to 105 bed capacity in the zonal hospital. And it's not just serving the people of Bori, it's also serving other local government areas such as Gukana, Thai local government area, Eleme, Oyibo, Opobo, and Korok. But realizing the dearth of health personnel across local government areas and communities was something that we very early on recognized, because every community is telling you our people are going to facilities and there are no healthcare workers there to attend to them. So the employment was not just for doctors, it was for doctors, nurses, other allied health professionals that would serve in hospitals such as the Bori Zonal Hospital. And then there's another challenge that people working in communities often face, which is accommodation. So they're working in communities, especially places like Bori that are not too far away from Port Harcourt. And many of them are residents in Port Harcourt. So staffing was another thing which is inbuilt into the projects for zonal hospitals. There's staff quarters for upwards of 50 members of staff and their families, and those are on site. They are linked to the power generating facilities for the hospital, so electricity is not a challenge for them at all. And so that's in having those ready personnel at the community level, people started having more confidence in going to the healthcare facilities, knowing that they're adequately staffed and there are staff on site. You don't have to wait for people to come from wherever else they live to provide the quality of care that's needed. So that's how we're able to navigate that. Thank you.
Thank you very much. A round of applause for the Honorable Commissioner for Health. All right. Just to really appreciate our online audience, we have over 100 people who have connected online. Please, a warm round of applause for those online. Yes. And special thanks to Austin's iPhone. I can see you taking the notes down. Please, a warm round of applause for Austin's iPhone. Thank you very much.
So we want to also briefly acknowledge the presence of Dr. Austin Osemeka. He's a board member for CIHP. Good afternoon, sir. We also want to acknowledge the presence of our partners from University of South Carolina. We are also online. Good afternoon, good morning, wherever you are. And we would also want to acknowledge the presence of Mrs. Fife Dawoju. She's a member of the steering committee for our SHE centers. Good afternoon, ma'am.
All right, to round off this session, we have one hand raised online, Abubakar Asar. Well, first of all, I'd like to take the comments on the chat box from Inen Naizikwe. Many thanks to all the panelists for very interesting and insightful discussion. As part of the new paradigm shift that must happen in the global transition is the need for more emphasis on prevention with the available resources. This will ultimately reduce the cost for secondary and tertiary care. Very well appreciated. And also from Oluwakemi Shawale, thanks to the Honorable Commissioner for Health, Rivers State, how can this 7-pillar strategy or approach be replicated in other states given the strides achieved? The question for you, ma'am. I'd like to take that question in a minute, and then Abubakar Hassan. Thank you.
The mic is with him.
Thank you, Oluwakemi Shawale, for that question. I think I'll also be a bit hesitant about replicating 100% because I'm one of those people that believes in context, believes in working your solutions to suit the environment. But thankfully, we have a Nigeria Health Commissioners Forum where we all share our experiences, we share our challenges, we meet formally, quarterly, and we engage nearly daily. And so we take lessons from each other, but always with the mindset of ensuring that it suits our context. Where we are in River State as at now may not be where my colleague in Gombe or in Edo or in Anambra may be at the same time. But we draw lessons from each other and we're steadily engaging and working also with the federal government so that there isn't that accusation that policies are developed nationally and thrown down at us at the subnational level to implement. So I would say that would be my response in terms of sharing our lessons.
A warm round of applause. Abubakar Hassan, do you want to take your question now? We can see your hands up. Abubakar Hassan, can you please unmute and ask your question? Otherwise, we will like to move.
It's been...
Okay, I think the hand has been up.
Yeah.
Okay. All right, so before we hand over the mic to round up the session, there's a question in the chat box from Stanley Mapa. My question is, I believe one major stronghold the private sector has is holding her workers very accountable for the money spent on them. How do we bring this level of accountability into the public sector, especially our health facilities? Okay, sir, over to you.
Okay, thank you very much. This is a very, very important question, and it's not in only the health sector. If you look at education sector, private institutions, they are not paying their workers like they pay government workers, but they've got more productivity than what you get. And the same thing applies to the health sector. So the question is, how do we do it? So what is very, very important is that we have to ensure that there is a connect between spending and the value we want to get for health. How do I mean? Are we asking the question that the money spent by Kaduna State, let me look at on the hotspots, on health last year, how much of health did the money buy? And then we now cascade it to the health facility. The money we are sending to the health facility, what is the level of productivity that we are getting? When I was in Kaduna, we visited a number of facilities, 4 midwives. At the end of the day, paid by, what's the National Midwife Service Scheme? 4 midwives in the facility, total delivery in a month 3. So if now, even we divide 3 by 4, it's not even up to 1 of facility. So I think it is very, very important at the level of our ministry, department, and agency to have a very, very clear target in terms of what is the performance target for health for this money that we are paying in this state. And then that goes to the facility level as well. And at times, some of these problems are not the problem of health workers alone. A lot of problem in the community, level of awareness and all those stuff, facilities that are proliferated in the sense that you have health workers, you have several health facilities, and guess what? Because we did not focus on the real ward level facilities, none of the facilities is able to operate for 24 hours. So a number of things, we have to use technology. Biometric attendance is very, very important. Our supervision has to be very supportive and digitized as well to know what is happening in each of these facilities. And there is going to be an appropriate reward and sanction mechanism, because if you get all the data, if nothing happens, nothing will change. Thank you.
Let's give him a round of applause. So as we round up, I'm going to have you speak to this accountability thing, because Jaffa is at the center. He's one of us. But you are there, and you have staff that report to you.
So, thank you very much. The issue of accountability, yesterday I was at the budget defense, so let me give you a case study. And we were reviewing revenue generated from health facilities, or maybe you asked about health facilities. And at the secondary health facilities, the performance was less than 30%. Because you have agents acting as revenue collectors that are independent of the civil service system that report to an independent revenue agency, as written in law by the previous administration and hasn't been changed. The tertiary health facility has an electronic medical record system. They shot up from less than 30 to almost 80%. Do you see that we are losing resources generated from our facilities that can actually run the facilities because there is no digitized accountability mechanism? Now we talk about intensification of supervision. We have an on-the-job supportive capacity building and integrated supportive supervision model. It's part of our budget. We do that every quarter in the state in partnership with the primary health care, and we go through and everything. Every time you go through, you profile recommendations, you must bring in all the stakeholders. Just like he said, you can't have a delivery ratio of less than 1 and say you're a midwife, you have no business being in that facility. You should be immediately posted to a facility where there is a clear need. You have facilities that have medical doctors where they do not particularly need a full-time medical doctor. Some of them can have a visiting medical doctor. And you can move that doctor full-time to another facility, and somebody can come maybe 2 days a week. I did it in a PHC because there was a need for a visiting clinician to augment the nursing care. So we must not only support and supervise and take the information, we must bring back things like mortality and morbidity review. Who died? Why? What went wrong? Why didn't they get better? What is happening? These committees have failed. The systems have failed. Yes, the red letter is there, but as he said, we want to see how much. And I want to know how many incubators did you send to my PHC so that I can go under cover of darkness and count. Is that not so? That is what happens in other countries. We have to be better.
Thank you very much. Okay. Yes, ma'am.
Sorry, thank you very much, and thanks to the panelists for an excellent job. But I still have a concern, and Dr. Gafar and Dr. Adeze, you are both closest to moving the needle on this. Because as we said, we don't want to just sit down here and talk. We know that one of the things I learned from Professor Fastusi, and I think it's a mantra in CIHP, we have what we call ISIS, intentionally stealing ideas shamelessly. So how do you get that to be the mantra, especially at the Governors Forum? You know, if we talk about accountability, Dr. Gafar, you talked about monies going now, at least in Naira. There is increased revenue at the state level, but we don't see any concomitant increase or any significant increase or investments, not just in health, but other social determinants across health. We don't see that. And so how would you put in that accountability framework? I want us to live here with a resolution that even if we need to talk and even go together as a team to that Governors Forum, how do we get politicians to really understand the business of health? It is sad because sometimes we have doctors as governors, but then I think something happens. When you get there, you just shift, you do a mindset shift, and you begin to really wonder if this person was ever a medical doctor. So for me, we keep talking about these things. We have the answers. And we know that one single fulcrum, one single shift at the Governors Forum that each state commits to do ABC will make a vast difference. Everybody says, oh, federal government, Tinubu, Hope, everything. This is not about the president. This is about each governor, each state, each local government, and each community. I remember, and I said, at least I'm not too young for that. Sorry, I'm going, but it's very important. This country has attained over 80% immunization coverage when Ransom Kuti was Minister of Health. It is not rocket science. It is doable. We've had functional world level health committees, world level development committees, who became the accountability framework at policemen, policewomen at the village level. I love the idea of the red letter, Dr. Gafar. But then we don't just copy ideas. We make sure we back the ideas we are copying, just as Dr. Rea said, in the context of who we are. First of all, how many people saw that red letter? How many LGAs saw that red letter? How many communities can relate with that red letter? What is that accountability? As Fam Tunji has said, if you come to my LGA, if you come to my community, let me know that I have 3 incubators, 20 healthcare providers, not the 2 I see every day, because 20 is on my payroll, but I see only 2. So it is how do we make sure we do that, and how do we make, I'm serious about this, the Governors Forum itself accountable to us as people of this nation, because they are not.
Can we get a round of applause for that question? Yes, we have to speak to that because accountability is the key. And I think one of us mentioned about transparency. Once information is out there, it's out there. How do we do this? I'm going to leave it to the 2 of you to close us out.
Okay, quickly. I think we have to start from what we know that works in Nigeria. If anything works, like I said, at the Nigerian Governors Forum, the governors are very, very sensitive to peer comparison. And we have to get our data right. And it's not long English, red and green. Where are you? No amber, because that is a hiding place, right? Governors are very, very sensitive, and we are able to push a lot of things in the past, equity fund and everything, even the health insurance for rivers and all this stuff. When they see that, why am I red? They quickly go back and call the commissioner. You know, everything falls back on the commissioner and say, why are we red? I think it's very, very important. Another thing which we have done recently is to do service coverage index, one single data that showed the state of service coverage in each of the states in Nigeria. And we're able to rank it. When we presented it, the representative of the Nigerian Governors Forum was there. They were scary that, oh, so we can easily rank and all those stuff. And the next thing is to present to all the governors as well. But the last thing I would like to say is that I think there are islands of success stories where the governors have taken ownership of their health. One example is Gombe State. They did health summit recently. And if you look at the indicators, a lot of improvement. Of course, it's not 100%. But when you see the governor talk, he takes the ownership, understand the issues, the problem, and everything, and he gives everybody the support. So I agree with you at the level of Nigerian Governors Forum, we need to do more. Dr. Abdulhab is there, is doing an excellent job. We have to support him with data and do analysis and do simple red and green so that the states will know where they are and they will follow up to see. Thank you very much.
Thank you very much for raising that comment, and I will definitely confirm what Dr. Kafar said about peer review. Thankfully, it is something that the Nigeria Governors Forum has been more consistent about, and I vividly remember from the example for state health insurance, I was very deliberate on taking up the role, having assessed what the issues were in the state, and having our state strategy in place, that my first technical memo to the governor was going to be on state health insurance. I felt that that was the first thing we were supposed to do and then kick off from there. Now that memo, of course, with government bureaucracy, I can attest to the fact that what moved the needle past 12 midnight was the peer review mechanism that happened a few days before the memo was released from the governor's office. That peer review mechanism is very strong. And like Dr. Gafar said, red and green. Let nobody feel like we're moving towards green. You're either not there or you're there. Or as we say in River State, if he didn't day, he didn't day. So for the other thing regarding the red letter, now the Honorable Coordinating Minister has sent out this red letter, and rightfully a lot of people don't even know what it means. They've seen a red letter, there's a large figure there. They may even think that money is still in the Federal Ministry of Health. Now, for those of us who are subnational leaders, and this is something that myself and the State Ministry of Health team discussed following the publication of that red letter, we will be writing to the National Primary Healthcare Development Agency, copying the Honorable Coordinating Minister, itemize the fund by local government. It is our responsibility to communicate what has been released from the federal government to our local government areas, either in cash or in kind. It is our responsibility as subnational leaders. The minister has put his foot on the pedal. It is now for us to ride the bike. Thank you.
Thank you so much to our panelists today. I think this concludes our session this afternoon, but we'll crave your indulgence. Just sit tight. You will join us in the unveiling of the SRT compendium. But just before we move on to that, we would like to thank especially Dr. Aishatu. She kindly stepped in on short notice to replace a panelist that was a no-show today. So it will be remiss of us not to properly introduce her. So just a brief profile for Dr. Aishatu. She obtained a certificate in leadership skills and a multicultural understanding as part of the World Wildlife Foundation, a United Nations sponsored program in Virginia, USA. She graduated from Ahmadu Bello University, Zaria, with a Bachelor of Medicine, Bachelor of Surgery, MBBS, and obtained postgraduate certificate in clinical medicine from Harvard Medical School, USA, in 2006 and 2007. She also received clinical training and a postgraduate diploma in fertility medicine from a Lagos-based fertility consortium in 2010. Her master's degree in medical field epidemiology is from the Centers for Disease Control's Nigerian-based field epidemiology program. She also has a PhD in energy and environment, a multidisciplinary research track with a specialty in air pollution and human health from the University of Lyon, France, in 2022. She's a recipient of over 7 international awards. She's also the country coordinator for Geneva Foundation for Medical Education and Research, a WHO collaborating center in education and research in human reproduction and community health and research initiative. Dr. Aishatu, welcome and thank you.
Thank you very much. You can agree with me that there was absolutely no way we could have missed a biography. Ladies and gentlemen, put your hands together again for Dr. Aisha.
right, so we'll be introducing another phenomenal lady, a part of the CIHP team, whose hard work and relentless efforts contributed to us being here today. Mrs. Obioma Ezibuka, you'll be joining us on stage. And please, the panelists will also join us to unveil the CIHP compendium.
Give it up for Mrs. Obioma. She takes the stage.
All right, so good afternoon, ladies and gentlemen, our distinguished guests, our esteemed partners, and our honored guests. It has truly been a special moment today for us. This is a scientific roundtable year 5. And so today we celebrate this journey. What you see here is not just a document. This compendium is not just a document. It captures the voices, the lessons, and the milestones that has defined our collective dialogue over the years. And so today, at this point, I would like to warmly invite our special guests that are here. I'm inviting Dr. Daisy Ore to please join us here. Yes, all the panel members, Dr. Gafar, Dr. Lawson, Dr. Folakemi, Anima Shang, our CEO. Yes, we have Dr. Kalu. Please join us here as we unveil the compendium. I think some of us can start. Yeah. Okay. All right. So, as we welcome others, we have Prof. Fatusi, please join us on stage too as well. So like I said, okay, our board members, Ma'am Praise, you can join us, Professor Query, yes, Mrs. Dukwesi, good afternoon. So like I said, the compendium is about the voices and the lessons and the milestones that we have had over the last 5 years. So ladies and gentlemen, let's put our hands together as we unveil this. Let's clap, thank you.
So I think just to say that the compendium really is a great report. It's a great publication that that articulates the learnings of the past 5 years and the actions we took after each of the SRT and how we have translated those learnings into actions. And we feel that it's very important that we document this and represent it so that it is there for the records, it is there for reference, and it is really in terms of making sure that it can be used, it can go very widely. So whilst we have a few copies, because we are also very, just to support Dr. Usman, especially in the environmental protection, we're very supportive of trees. We're not going to waste paper. We just have a few copies printed out, and this is going to be launched online as soon as we finish this launching. So it's going to be accessible at all the CIHP social media handle and on our website. So if you don't know our website, it's www.cihpng.org. So once you do that, you can download a copy for your reference. And I want to acknowledge the co-authors. Valentine, I see you hiding in the corner. Please come here, and Obioma Azuruwa. But more importantly, to also acknowledge every single member of CIHP who has, in one way or the other, through the 5 years of the SRT, continued to work robustly and contribute to its progress. Some are still with us, some have left and jackpot to greener pastures, but this is all for all of us. So I'm going to hand over the mic to Prof, who is the chairman of the board, who is here, and Dr. Dopesi will support him, so please come down. Yes. And Professor Fatusi is actually a member of our board. So I think we forgot to say that, you know. So before we talk about keynote, it's part of us. So we are proud to own him. So please, the three of you should step out and do this on behalf of the CIHP. Okay, sir. Prof will do it.
All right. It gives me real pleasure to have the honor and presence to unveil this edifice, as it were, with a compendium, which, if I know the excellent functionality of Bola et al., will obviously be an excellent contribution to science and to literature, and more relevantly, to the health of our people. Through this, we thank God for all protections and to continue to grant us the peace and the wisdom to do what is right for our struggling masses of Nigeria. Amen.
Ladies and gentlemen, a round of applause. A round of applause. Thank you, thank you. Thank you. Congratulations to CIHP. Whoa, keep rolling, keep rolling, keep rolling. Keep those hands rolling. Awesome, 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 awesome. Awesome. Please keep clapping if your hands are not too tight. Please keep clapping. Thank you very much.
Thank God for everything.
So we'd like to take a picture, please. Could you please raise your copies facing the camera upright? All right. Are we set for the photograph? Thank you very much, ladies and gentlemen. A warm round of applause for the Scientific Roundtable Compendium. 5 years of progressive data-driven health systems dialogue. Thank you so much. Thank you. Thank you to the team. Thank you, Obioma and Valentine. Thank you. All right. Right about now, we'll be breaking for our lunch. Okay. So we'll be heading straight to the ballroom. Excuse me. Hello? Okay, please, let's take this information. Thank you, thank you, thank you. Thank you, thank you, thank you. So we're breaking for lunch and we'll be back at 4 p.m. So we'll have a 30-minute lunch. We'll be back at 4 p.m. to round off the 5th Scientific Roundtable. So ladies and gentlemen, let's break right now for lunch. It's at the restaurant in the hotel. It's the 8th floor. It's the 8th floor in the hotel. The restaurant is the 8th floor. Okay, sorry, I beg your pardon. It's on the ground floor. It's on the ground floor. So let's break now for lunch and we head back at 4 p.m. 4 p.m. straight, 4 p.m. sharp. 4 p.m. we'll be back to round off the conversations. Thank you so much, ladies and gentlemen. Thank you so much. Let's quickly break for lunch now and come back at 4 p.m. Please, while you eat, please also take a look at your watch. Thank you.
I think me too.
Welcome back, distinguished ladies and gentlemen. I hope you enjoyed your lunch. Welcome back. We're about to round off the 5th scientific roundtable. We just have two to three more sessions, and then we're done. The choreographers, are you ready? So we can start this session. So we'll be starting in the next 3 minutes. We'll be kicking off the final session of the day in 3 minutes. Thank you. Welcome back. Welcome back, distinguished ladies and gentlemen. It's been an amazing day so far. Welcome back. I hope you enjoyed your lunch. You've been amazing today, so please, you deserve a warm round of applause. Please give yourselves a warm round of applause. All right. You are now going to look at the next person sitting close to you and give that person a warm round of applause. Say thank you for being... Thank you for being amazing. Thank you for being amazing. So we're wrapping up shortly. And we have a couple of set of people who will be taking us or giving us a beautiful, beautiful choreographic display. They are the Primer Space from eCrafty, a developmental advocacy organization. So we'd like to invite them for their choreography presentation. Ladies and gentlemen, put your hands together for Prima Space. Prima Space, you have the stage. Thank you. Don't stop clapping, don't stop clapping, don't stop clapping. Thank you so much. That was amazing. That was amazing. I really enjoyed it. Thank you, Prime Space, and thank you, eCrafty, for the awesome presentation. Ladies and gentlemen, we have one more agenda, and then we will wrap this up. I'd like to call right now for the transition NGT prep, that's the nominal group technique. And taking us for this session is Mr. Adewale Ogunaike and David Odowanjo. Please put your hands together for David Odowanjo. Okay. All right, Mr. Adewale, over to you. Thank you so much.
Good afternoon, everyone. Yeah, thank you so much, my CEO, for granting us the opportunity to present the nominal group technique. So with this session, we hope to crystallize all the discussion that have happened since morning into something scientific that we can publish to the rest of the world for what we have done here today. So the next slide, please. So I won't want to bore us because time is really gone. But I'll just say that most of us have been involved in one focus group discussion or the other. So this is something like that. But instead of the traditional group discussion, nominal group technique is one that instead of having the most vocal in a group idea being the one that will be documented, nominal group technique gives us the opportunity of facilitating group idea generation and decision making in priority setting. Like I said, NGT generates collective, prioritized, and actionable solutions. And so this is just the benefits for participants, prevent dominant members controlling, ensures relative equal participation, and improves group productivity. And for us, facilitator is more cost-effective, qualitative and quantitative results, unlike the FGD that is just qualitative, and we can see immediate results instead of having to go and listen to the recording of focus group discussion. And the way we are going to implement this, so group formation, 3 tables adjacent. My colleague is placing numbers across the tables now. So we'll have 5 groups because of the number. So I'll crave our indulgence to just do 1 to 5 because we want to really spread the room so that we can have a blend of ideas. So, Ma, can we start from just 1 to 5? So she's in group 1. 1. Move around. You have number 2, 3, 4, 5. So 1, 2. No, she's already in a group. Yeah, so I will crave our indulgence that all ones should go to the tables labeled 1. So there are 2 tables to each group. So we have 5 groups. Please, can we do that in 2-3 minutes, please? So all 1 to the tables labeled 1, then all 2s to the tables labeled 2. Yes.
think of what we'll do before we tell them.
It's also from here we're entering the research evaluation. It's the same thing, yes. It's the same thing, yes. So this is the first 10 minutes to do the understanding of it's the same thing. Thank you. Thank you so much. So yeah, so each group we have its own facilitators. My senior colleagues and are going to be moderating the table. Dr. Phillips, Ray Desmond, Mr. Funshaw, Madame Laurentia, Evelyn Ure. Who else? Yeah. So do we have all the group facilitators in each group now? Okay. Yeah, Famike, thank you so much. All right, so we will be displaying some QR codes. So we'll be displaying some QR codes just so to get our ideas. And the facilitators in each group will also put us through on what to do. If there is any need for any clarification, I'll also move around so that we can do this fast because time has really gone. So, can you display the first QR code? 5. Yes. Should be group 6. Oh, okay. So for our online participants, if you are willing to participate in this, you are automatically in group 6. Yes. For the online participants, they will be in group 6. Okay. So for the social demographics, you have the barcode on your table, and you can snap from here, just so that. You don't have? Mr. Fisher? On the other table, all I want the social demographic code. No, the second table. No, is it group 2? Yes. So once we are done, the facilitators, please just let me know. Can we make this bigger? Can we make the QR code bigger? Make it cover the whole screen. So I think we just have 6 to 7 questions there. So are we done so that we can go to the next part of this? We are good. The group facilitators, are we good? So I'll take that as a yes, that we are done. Evelyn, we are done. Right, thank you. Madam Law? Or Dr. Phillips, sir? Mr. Finshaw? Mr. Finshaw? Are we done with it? Ray Desmond? We are done. Thank you so much. Display the first question, please. Okay, so this is the first question. So how this works is that individually, we will answer this question individually. So once we are done with that stage, then as a group, we will now reference, we will check with each other what our responses are. We will identify similar items, and we will now list, maybe we will have 7 to 10 unique ideas on this question. After that, we'll streamline those responses to just 5. And I will be needing those 5 responses from us. So I'll take that again. Individual brainstorming first. Okay, so once you're able to have 5 answers to this question individually, you will cross-check your own response with colleagues on the table. We'll identify 5 unique ones as a group, and that is what I will be needing. Is that clear? Is it clear? Thank you. Okay. 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 But do you have marker? We don't have it. Five. Adedayo, let the 5th one show. So some persons are thinking it's 4. Yeah. Reduce the screen so that the question can show. Sir. You can even reduce the percentage from 160 to maybe 150. Reduce the screen percentage to 150. So that to come down a bit. Yes. Yeah. The question, you can make it bigger,
Yes, please. Make the question. Is the question
just increase the font size of the question, please. Yeah. Can make it 15 or 20. Yeah. Thank you so much. So, do we have our individual 5 now? No discussion at this point. It's individual brainstorming now. Yes. So, as a group, once we have our 5, let's start collating. Yeah. Yeah, that's it now. So I'm just being informed that we'll be recognizing the first group to finish, to have their top 5 eventually. Long stay, yeah. So please limit your responses to 1 word, 2 words maximum. I forgot to mention that earlier, so that we can easily group it. 1 word, 2 words maximum, please. Yeah, so let's start discussing our ideas now as a group. Yeah, Dr. Phillips is the person. Dr. Phillips. Yeah, so. So that you should just reply to that last one I sent.
Because I don't say before Ibrahim sent 5. How many minutes will it take? What will they be doing while they are waiting? What will they be doing while they are waiting? They can't be sitting and waiting. So what we will do, immediately we'll load down, give them the bias. Give them the bias in their group. I know what are you doing now, the first one? Already, after I'm going to bring them for that there are 5 that they have in their group. The 5 that they have, we start with strategies. We start discussing strategies to address. Then before they finish discussing this top 5, we'll now say, okay, hold on the strategy discussion. Look at this, what you have discussed. Look at this 5 that have been ranked as the top 5 issues. Narrow your strategies to 5. So while they are working on that, 5, we'll now take it back again. They will feed that 5 and go. So by the time you are now coming to the sustainable solutions, discuss on that your 5 strategies.
Okay.
So while that's why
they are seeing the other question. No,
so as they are doing that one, discussing on the 5 strategies, this guy will quickly run what strategies are top 5. That's their solution. Then now say, okay, hold on your discussion, pause on your discussion. So after that, this is the consensus 5 strategies. So narrow your conversation to this 5.
So you are working with Adedeji?
Yes.
Thank you. So just look out for me for Ibrahim. So do we have a consensus now? 5?
So we have our own top 5 here. Yeah. Evening. How many do you have? So let's start collating our top 5 now. Can anybody see? The barcode for the barrier. No, this social demographic. So we can start uploading our top 5 into the barcodes now. They should start uploading. So let's start uploading to the barrier barcode now. 1 upload per group, please. 1 upload per group.
Sister, we are too many of us.
Accountability, ownership. Yes. Yes.
To discussing strategies that will address
Those
the
five
top
that they
5
have.
barriers.
Yes.
Announce it now.
So thank you. I've seen some teams uploading their top 5. So let's go to the next question. So based on our top 5, let's start answering this question. Just brainstorming. Based on the top 5 that the team was able to identify, answer this question based on your top 5. On your collective top 5. Don't worry. So based on your top 5, let's start answering this question. Based on your top 5. Just individual brainstorming first. 1 upload per team, please. 1 upload per team. Okay. Ma, you sent back. Okay. Desmond, your team has sent.
Mr. Funshaw, your team are saying? Doctor. What? So, they are taking their time. Desmond, your
My group has uploaded.
okay, so that's two,
That's
three.
three now.
No, it's only two. One, two.
My group Funshaw has
Okay,
uploaded.
Mr. Funshaw.
They have
Mr.
uploaded
Funshaw.
Barrier. They've uploaded Barrier.
Okay.
Don't worry.
So that's
who has
three.
not uploaded
One.
Barrier? Yeah, yes.
And so you should just hold on.
Okay.
Go convince that thing. So the sticky notes you use for the first session, please don't discard it. Please. Yes, don't discard it. Yeah, thank you. The sticky notes you used in the first session, please don't discard it. Yeah, please help us just put it together. That's why we say individual strategic generation. Once everybody's done, that's when we can get the top 5. Overall.
Based on the overall barrier.
Yes.
That is what you uploaded.
It's based on the overall barrier. That's why
That you write this strategy.
that's why she's projecting.
The one you uploaded from the general house, pick from their individual.
That's why we say individual first. Once we group all the barriers, we still have top 5. I'm sure some of yours may make it or may not. Evelyn.
start with. Okay. So you need to write those top 5 out so that. Okay. Thank you. So I think it's your single one. So the infrastructure, is it poor infrastructure? So okay, yeah. So that's when we are doing the analysis. And what's the last one? You said the HRH, help us make it full, please. Okay, the HRH. That's full. Human resources. What's the next one? Sorry. So this is the last thing. This is the last thing. Yes, Evelyn has done that. Yes.
So they should have a list of strategies that will address their
Barriers.
and then they can, when they have the list, they can now narrow down to 5 top, and they would like to implement, and they would like to see implemented in their group. So once we put that, then we can come back.
Fine. Thank you, sir.
Let's just complete the cycle. Strategy, barrier, and how to sustain. The way we now finish based on all their solution. By then, they have said, so come, let me change their approach. Hold on.
They are just doing that now.
They will submit it. Let them just submit it. So, timing difference is going to affect that analysis. So what we should do, let every group complete 3 steps. While they are completing the 12 steps, the other one will be ready. They will present it to everyone. They will now present the outcome for barrier. Everybody sees the consensus. And then present the outcome for the strategy as well. So they announce all these 5 barriers. They will see that this is the then the strategy.
Consensus 5 will not influence this strategy.
It will influence, but it will be in a cycle again. So we'll now present this 5 to them. And say,
So, sir, no, we are not waiting again.
we should
So, based on your top 5,
we should just go ahead.
Yes,
So listen to me. So the way I'm on. So based on and then these are the top 5 strategies. Also put out. And this, you understand? And then so we now say so we hold them on the sustainability will come. So based on this new 5, we would like you to look at the strategies that you saw against these barriers and pick the 5. I mean, no. We'll not be able to We'll bring the top barriers and the top strategies out. So these are the top 5 barriers. Take note of it. Then these are the top 5 strategies. Discuss this and rank them in order of 1. I mean, discuss this and put them for the sustainability.
Okay, so it means they'll still wait for sustainability.
No, we'll not need to wait. Let them just bring it. We'll now rank it because we'll exhaust all the sustainability.
Okay, so barriers are ready. Time is sharing. So get stage.
Yes, now.
Yes, sir.
Yes, I do, sir. Yes, I do. So, they are discussing this now. They should submit also. So that gives Mr. Dedeji. Where is he? Where's Adedeji? So the idea is to project the barcode for this one. And the mail is supposed to come from Ibrahim. There's no email. There's no email from Ibrahim. So Laura, drop from where the guy go now? Ibrahim Suleiman. Yes. Are they dropped? It's only a distribution mail. Yeah, they don't draft. No, it's mail. Email. So we start aligning. Sir, can you help us make that font bigger? This font. Make it bigger. Where did they go now? Where are they dying? No, his email is open. No, not barcode. No. The font of this one, yeah.
Okay. Which page now?
Just highlight. Where? Yeah, the same.
Ibrahim has sent the mail over.
Hold on. Let them do sustainability first.
Okay.
How many mailers?
No, we are copied, but we need to show.
Leave that one first. Download it and keep. Don't show anything here.
So my guys are already on.
So call Ibrahim once he finishes that, he should also send.
Okay.
They scanned the second barcode.
My guys have sent the second one. They don't. We are fast.
So show the second barcode.
Not second.
For the strategy.
For the online. Yes.
That's the brand.
Maybe it's this one.
So thank you for the rich discussion that is going on. Please start uploading your responses for your strategies. So your strategies, please.
Strategy, they are listing them. They are listing the strategies. Okay.
Yeah, they are listing. Group 6, okay. So to our online participants, you can upload your strategies now. So timing, time. If you have uploaded your strategies, can I see your hand up, please? All right, now, so do we have our submissions for our strategies now?
Top 5.
Yes.
I don't
The
know.
top 5 are in
2
here.
words, sir.
So,
1, 2 words.
no, they have.
No, be hyphenated. Don't use hyphen. Join for all letters. Top 2 words.
You are making the perfect the enemy of success. You know they say it like that. When you make perfect the enemy of success, you then create a barrier.
Analysis.
So, I'm
3 words. Yeah.
Prof, barrier is complete. Let's see how many construction.
Don't look for way to offer.
How many strategies have you?
Now people should move to sustainability. Let them just discuss something. Let that be sorted. They will now present that from the discussion, these are the top 5 barriers, these are the top 5 strategies. Please look at your sustainability conversation and tailor it towards this slide. So that time, because you snap it, when we post it there, the top 5, you should snap it for them. Snap it and look at it. Guide their discussion. Look at it, guide their discussion. Okay, so thank you, sir.
So I'm sure we are rounding up now. All right, so I'm sure we've submitted our top 5 strategies. So based on your top 5 strategies, we can address these sustainability questions now. And that is the last step. Thank you.
finish now. Yes, that's communication. I just say why you removing it, just drop and just be like, and the word is.
Now you come my guys then they fought so I don't tell them say when they finish me they know upload it.
Don't give them that. They should not upload it. When they upload now, why should they upload it? So Dr. Collins won. Child. The Dr. Collins won them to remove certification barrier and like they are sustainable possible and safe. So, because you should go. He said they are on the third one, sir. It doesn't count. Two words. Two words. I'm seeing statements there.
Papa.
Yes,
Abi, because we need to show something. I am on my guy is waiting.
first, so I want to go sit down so that you now. I'll go and check. Yeah, I have. ready now? Are we ready now? Has it done the strategy? Ready? So when you put when it's done, now people see now you now put up the strategy. So you announce and please everybody just put on this thing. This has all one via the camera. This is the five. The other one is five. So we now narrow down.
Hello, everyone. Hello. Give me 2 minutes of your time. 2 minutes of your time while you're still talking sustainability. I know that's where the meat of the discussion is. So please look at the board. So look at the board, please. So from all your discussions, that's your group. Good, good. So from all your discussions, these are the top 5 barriers that came up from all your group discussions. And I can see some persons are already claiming their group. Yes, and I'm sure most of you, your groups are here. So take a snapshot of this. Take a snapshot of this. Take a snapshot. Oh, sorry. Okay, so Dayo, the next one. Hold on. Okay, so just like we did the ranking for all 30 groups, all 30 submissions, that's from group 1 to group 6, just like we did for the barrier, for the strategies, the same thing. So these are what came up as top 5 on the list. So take a snapshot as well too. Take a snapshot. So now, what we'll do in the next 5 to 10 minutes, and we are done, is with the sustainability you're discussing, so discuss to align with these barriers and these strategies. Okay? So this top 5, so we are narrowing it down. So you've seen the top 5 barriers, the top 5 strategies, right? So discuss sustainability around this, in line with what you're doing so far. So we'll wrap in the next 5 to 10 minutes.
So hello. So maybe just to put an icing on the cake. So all your submissions was run through an AI supported analytical table, and all of them came out. So those 5 that you see there, they occurred with the highest frequency. Some 10 times, some 5, some 2, depending on your submissions, right? So we narrowed down that 5. So these are the other 5 that have come out. We know that the sustainability discussion is on, and you have a lot of things that you are addressing. But let's make sure that we address these 5 at the minimum, and then the ones we have will be additions that we can layer. Thank you. I mean, sustainability. You are done. Oh, you are done. Check, verify.
Verify.
Implementing right now. Well, implementation phase. As even uploaded. We're implementing now. We're implementation. Yeah. We're building systems. We're building systems, bro.
So we have 4 minutes to wrap up. 4 minutes to wrap up. Four minutes to wrap up. 4 minutes to wrap up. Yeah. No. Okay. Okay. Thank you. Thank you. 4 minutes to go. 3 minutes more. 3 minutes more. Three minutes more. We have 3 minutes to go. 3 minutes to go. 2 minutes more. 2 minutes more. I think this. One minute more. And we are done. Back to Dema. Thank you so much. So a round of applause for yourself. Thank you so much.
Thank you so much. Thank you. A round of applause for yourselves, ladies and gentlemen. Keep clapping for yourselves. Keep clapping for yourselves. Thank you. Thank you. All right. Ladies and gentlemen, I'd like to thank every one of us for participating actively in the SRT. Thank you, thank you. Can we be seated, please? Can we be seated, please? We're rounding up in 5 minutes, in less than 5 minutes. Thank you. Please, can we be seated, please? We're done with this session, and then we take the vote of thanks, and we're done. So I'd like to call Dr. David Barnabas to give the vote of thanks, and then we'll be done. Mr. David Barnabas is the Director, Laboratory Services Unit, CIHP. Thank you very much, sir.
Thank you. So I understand I will do this while people are still standing and still talking about things that have happened. So please, on behalf of the board and the Chief Executive Officer, Dr. Bolade Oyedun, I really want to appreciate everyone. Most importantly, for staying to this hour, to this very minute, and to be part of the discussion that just ended. We really want to appreciate you from the depth of our hearts. This wouldn't have been possible, the SRT5 wouldn't have been possible without you. Your active participation, your valuable discussions, and all the insight. I learned a lot today. For every session, there was a lot, full pack to take home. So let's keep the discussion, let's keep doing what we discussed about, that is walking the talk. And we look forward to seeing you in SRT 6.0. Let's keep the communication, let's keep the networking. We look forward to partner with you, and we love you. I want to end it like that. So thank you for coming, and we wish you journey mercies to your destinations. We wish you the very best. Thank you. Thank you. And most importantly, and those who participated virtually. And I can tell you it's more difficult participating in an event virtually more than even being physical. It takes a lot of discipline. It takes a lot of dedication. So I turn now again to look through those. As I'm looking at my screen, I want to believe I'm looking at all and everyone that participated online. So thank you for staying through. We understand the challenges you may have faced, but despite that, you stayed through to this hour. So please, a thumbs up for them. I will really appreciate you. Thank you.
Thank you very much, Mr. Barnabas. Yeah, just to give, yes.
I can see Dr. Tony Smith, the member board of directors of CIHP. Thank you for staying through to this very time and for the engagement. I know a lot of information and engagement have been on the group, the chat group as well. So on behalf of the board and also the CEO here and everyone seated here, and also I would say on behalf of you representing all the online community. And we also see a lot of other staff of the organization, even across the state. The president of NEP1 as well. Okay, resident M1, okay. M1, okay. Dr. Zainab Kwaru, the president of M1, yes. Medical Women Association of Nigeria, I guess. So thank you so much for coming. And a lot of others that I will be able to call by name all through. We really appreciate you, because I know if we roll this, we'll get to page 2, page 3, and thereabout. So thank you, we see you, and we'll have the details. We'll continue engaging you. Thank you, thank you.
Thank you very much, sir. Yes, still thanking the online participants. We had over 200 persons who joined online. Over 200 persons. That's amazing. That's amazing. You rock. You rock. And then we want to say 3 bozers, because we are less informal now. So we'd like to give 3 bozers to our online community. Want to go? Boza, Boza, Boza. Thank you so much. And then to you. Yes, I'm truly Ife. I'm truly Ife, true and true. The Boza is Ife-ized. Ladies and gentlemen, thank you so much for being actively involved and participating so much in this SRT 5.0. Before we go, I'd like to take 2 feedbacks from you. You tell us the key moments of this SRT and what your take home will be for today. Just anybody. 2 persons. Anybody? Oh, give it up for him. Give it up for Ali. Yes, Ali? Amit. All right.
I think for me, the biggest takeaway is how much commitment and creativity and passion there is in Nigeria and exhibited through this roundtable today. And I'm really excited to see and witness the transformation that will happen in Nigeria health system in the next few years. Thank you.
And I can go. So I think main takeaway for me is to see the drive for innovation and how much drive there is to get rid of the dependency on the external funding. So that was very, very nice to see and very inspiring, I must say. Thank you.
Great. Thank you so much. A round of applause for yourselves. Ladies and gentlemen, it's been an amazing day. I'd like to, before I thank Dr. Bola, we have the cocktail event outside after this session. We are all going straight to the cocktail event. We are going to have fun. Please, disclaimer, nobody's going to talk about any strategy. Nobody's going to talk about any whatever. Go and have fun. We've talked from morning till evening. We've had various wonderful discussions around innovations. Now it's time to unwind. I like to see you dance. I'm going to make you dance. You're going to dance tonight. Yes, exactly. So thank you so much, ladies and gentlemen. Sorry? Oh, thank you.
Your energy is so inspiring, Thank you.
Thank you for the feedback. Thank you so much. I appreciate it. Thank you so much, Dr. Bola, for the opportunity to host the 5th Scientific Roundtable. It's such a huge honor. I do not take it for granted. Thank you so much. On behalf of myself, Dr. Inyang, we say a very, very big thank you. Thank you, Ma. Thank you, Ma. Thank you, Ma. Thank you so much. Ladies and gentlemen, from me to you is God bless you. Thank you. See you again next year, God willing. Good night, everyone, and enjoy the rest of your evening. And just to say, my suit was also from CIHP, Dr. Bola. Sorry. Dr. Adebisi Samad, yes. So he makes good clothing. So CIHP, we are encouraging our own. We are very innovative. So ladies and gentlemen, so from Billard, ladies and gentlemen, good night and enjoy the rest of you. Yes.
If you go on Instagram, it says I'm his greatest publicist. You go on B-I-L-A-D, Bilad. So he does clothes in case you want something. He can send it across the world. He's one of us.
Yes, he's one of us. Okay.
Once you do that, please put Bola's name as a code for discount.
Good night, everyone. Please let's proceed to the cocktail. Thank you so much, and God bless you.
My biggest takeaway from today is how incredible it is when people from so many different communities, organizations, different sectors of the government come together to really think deeply about how we can promote the well-being of vulnerable adolescents.